Okay, good morning and welcome to the 9th meeting on 2014 of the Health and Sport Committee. As usual, I would ask everyone in the room to switch off mobile phones, Blackberries and other wireless devices as they interfere with the sound system. Some members and officials are using tablet devices, that is instead of hard copies of their papers. The first item on the agenda today is subordinate legislation, and we have two affirmative instruments before us. The first instrument is Community Care, Personal Care and Nursing Care Scotland Amendment Regulations 2014 in draft form. As usual with affirmative instruments, we will have an evidence-taking session with the Cabinet Secretary and his officials on the instrument. Once we have had all our questions answered, we will then move to a formal debate on the motion. So therefore, can I welcome the Cabinet Secretary and his officials this morning. Alec Neil, Cabinet Secretary for Health and Wellbeing. Good morning.
Good morning.
And Gillian Barclay, Head of Unit Integration and Reshaping Care, Scottish Government. Can I, welcome, can I invite the Cabinet Secretary to make a brief opening statement?
Great, thank you very much indeed, Convener. I will be brief. The draft affirmative order before the committee today reflects the Scottish Government's commitment to increase free personal and nursing care payments in line with inflation. The order, if approved, will continue to benefit vulnerable older people. Last year, we increased the personal and nursing care payments for residents in care homes in line with inflation. The regulations will further increase in line with inflation the weekly payments for personal care by £3 to £169 per week. It will increase the additional nursing care payments of £2 by £2 to £77 per week. In line with our partnership arrangements with local government, councils will meet the cost of the inflationary increases, totalling around £2.45 million in 2014-15. An additional amount of £1.5 million annually was added to the funding for local authorities in October 2012 to cover these additional costs in the current spending review period up to 2014-15. The free personal and nursing care policy continues to command strong support, and I hope that the draft order can receive this committee's support, and I'm happy to take any questions, Convener.
Thank you very much, Cabinet Secretary. Do any committee members have any questions to the Cabinet Secretary or officials? Okay, no one has caught my eye, so I'll assume there are no questions. So we now move to agenda item.
Can I just ask
you certainly can,
just
yes.
under the, sorry, I'm shuffling through my papers. My machine is a bit slow this morning. On the financial implications, you said that 1.5 million has been budgeted for, but the cost of the increase is 2.45. Who will make up the difference?
Well, under the agreement, which goes way back to the introduction of free personal care, the local authorities make up the difference.
So local authorities will have to find that money.
Okay, before I move on, are there any additional questions? Okay, thank you. Well, there will be no more questions when I move to agenda item 2, which we move to a formal debate on the affirmative SSI, in which we have just taken evidence. At this stage, can I remind committee members that they should not put questions directly to the Cabinet Secretary during this session, as it is a formal debate and officials may not speak at this point of proceedings. At this stage, can I first of all invite the Cabinet Secretary to move the motion S4M 09334?
I move accordingly, Convener.
Thank you very much. Would any members before us today wish to contribute to the debate? Okay, no members intimated they wish to contribute to the debate, so can I ask the Cabinet Secretary whether he wishes to sum up?
No, thank you.
Okay, thank you, Cabinet Secretary. Therefore, can I put the question on the motion that Community Care, Personal Care and Nursing Care Scotland Amendment Regulations 2014 in draft form be approved? Are we all agreed? Yes. Okay, we are agreed. Thank you very much. So we now move to agenda item 3, which is also subordinate legislation. Agenda item 3 is to take evidence on our second affirmative instrument of the day, that being the Patients' Rights Treatment Time Guarantee Scotland Amendment Regulations 2014, and that was a rather slick change of personnel there. I'm very impressed. Once again, we have an evidence-taking session with the Cabinet Secretary and his officials on this instrument. So can I once again welcome the Cabinet Secretary back, but also welcome his officials, Margaret Duncan, Head of Branch Access Support, and Ailsa Garland, Principal Legal Officer, Scottish Government. Welcome this morning. Okay, once again, can I invite the Cabinet Secretary to make a brief opening statement?
Thank you, Convener. The Patient Rights Treatment Guarantee Amendment Regulations is what we're now discussing. The draft regulations make amendments to earlier regulations from 2012. The main amendments inserting a new Regulation 4A make provision for periods of time that will not count towards the waiting time calculation where a patient has specifically requested to have their treatment carried out by a specific consultant or treated locally. This was at the request of NHS Board's chief executives, who indicated that for a very few patients it would be appropriate to meet such a request. We do not expect these to be high numbers, and such cases should be exceptional, as National Health Service in Scotland policy is to have patients booked to a clinical team rather than individual consultants. We're also conscious of the need to ensure that such requests for treatment locally do not negatively impact on boards planning for delivering services. The amendments make clear that part of the process of a board accommodating these specific requests in relation to consultants or local treatment involves the patient being made aware that this will have an impact on the calculation of the waiting time for treatment, and the patient must accept that there will then possibly be a delay. We also intend to amend the treatment time guarantee directions to require boards to write to a patient to inform them of the impact of their request on the waiting time calculation, and to include in their patient administration systems details of why it was reasonable and clinically appropriate to meet such a request. This will enable the local audits to review the use of such periods of unavailability and ensure they're not being applied to deal with local capacity issues. The draft regulations make some other amendments to the 2012 regulations. We gave a commitment in 2012 to review the exceptions to the treatment time guarantee, and I'm pleased that the draft regulations make amendments to remove the following exceptions. 1. The exception for treatment of injuries, deformities or disease of the spine by an injection or surgical intervention will be removed from the 1st of April 2014. And the exception for designated national specialist services for the surgical intervention of spinal scoliosis will be removed from the 1st of October 2014. This means that more treatments and services will be subject to the treatment time guarantee. We've also made an amendment to clarify the definition of ophthalmic medical practitioner to address the Subordinate Legislation Committee's comment during the passage of the 2012 regulations in March 2012. And I'm happy to answer questions, Convener.
Thank you very much, Cabinet Secretary. Can I ask members whether there are any questions? I see Dr Simpson and Ms Grant. Mr Simpson.
Can I first of all welcome the reduction in the exceptions for spinal problems, which is very welcome. I think the concept of national service division delivery services particularly being not exempt is appropriate because they are national services. However, I want to talk mainly about the other change that is being made, and again, to welcome it. The Cabinet Secretary will remember that in the Audit Scotland review of waiting times, when they looked at Lothian, which was one particular situation, the other board that was actually named in their report quite strongly was Forth Valley. And in fact, they had a significant number of patients who were being designated as socially unavailable. But the reason for that social unavailability was the patient's choice to stay locally with their consultant rather than to travel. Now, it seems to me this amendment actually tackles this problem, but I would slightly question the Cabinet Secretary's comment that this is not expected to be a significant number of patients. I say this because the treatment time guarantee has yet to be met. The 12-week guarantee has yet to be met by the majority of health boards. And they are having increasing difficulty, as shown, the pressures that they're under. So actually offering patients that choice seems to me to be very appropriate. If I don't want to travel to Clydebank, to the Golden Jubilee, or to a private hospital out with my area, because I wish to stay with my local consultant, that is a perfectly reasonable choice for the patient to make.
That this is an opportunity for questions, and yes, I'm happy for you to continue, but there will be an opportunity to debate after questions have been asked. Okay. So maybe I should come to a question.
So my question is just coming up, Chair, okay. And my question is therefore that the specifics, I mean, we have a very complex system of coding. The specifics, will the specifics actually allow the patient to make that choice if, and the board to offer it, provided it doesn't actually have a long-term loss, which was the previous problem with the very simple abeyance system that was being aimed. So will the patients actually be offered that choice if the board is unable for capacity reasons or holidays or sickness of a consultant or an important member of the team being off to make that choice?
I think we should make a distinction between something in terms of the provider not being able to meet a particular deadline, for example, because a consultant is ill or sick, and the situation which we're describing here, where the patient is making a very proactive, conscientious decision to request that they be treated locally rather than, say, go to the Golden Jubilee. In the latter case, the patient obviously has that right to do that, and that's absolutely right. I think we're agreed on that. It's important to do two things, though. Number one, to record that, and we're providing and making it a requirement that in those situations the board writes to the patient explaining in writing the impact of the patient's decision to exercise that option. But secondly, that in the records, we're also recording exactly what has happened, because when you look back at the Auditor General's report and what happened in Lothian and Forth Valley, was that the suspicion was, particularly in Lothian, the unavailability, and it was called social unavailability at that time. Obviously, we've redefined these unavailabilities, but that in Lothian, obviously, that was abused by the board. And we are building in deliberately systems to try to ensure that there is no abuse either by the patient or by the board.
So can I just be clear? If the patient has to make a proactive choice, so at what point are they required to make that proactive choice?
Well, normally the patient would be offered an appointment for their treatment. So that the board might write out, let us say it is a cataract operation. And the board writes to the patient and offers the patient an appointment in the Golden Jubilee on Friday, the 10th of October, let's say. The patient then would get in touch with the board and say, look, I really don't want to go to the Golden Jubilee. I would much prefer to get this done locally or by a named consultant, even in the Golden Jubilee. It could be a named consultant in the Golden Jubilee they want it done by. In that case, the board then would withdraw the offer, the original offer, and make a new offer at the earliest possible opportunity for either the local hospital, if that was the patient's choice, or for the named consultant in the Golden Jubilee, if that was the patient's choice. But they would then write to the patient, they would do it verbally, I would expect, but they must write to the patient in black and white and say, let me make it clear this is your choice, and therefore you will have to wait a bit longer for this procedure because you want it done locally or by a named consultant. And the systems will reflect that as well. So the opportunity to have a repeat of Lothian is hopefully not there.
Thank you. Thank you, Dr. Simpson. Now, Mr. Lyle, I know you've got a supplementary, but so does Rhoda Grant and Rhoda Cotton. But so is Rhoda specifically on that point as well.
I'm maybe not so delighted with the change. Covering the area I do, it's not always a choice whether or not you can travel that far from home. People travel huge distances to access health services. And what has been happening is people are being offered out of board area appointments. And if they don't take them, their waiting time guarantee is halted. And that to me is really difficult, especially elderly people who might want a carer with them. They can't take that unless the health board is looking to pay for a carer, and people with young families who also have caring responsibilities to be removed from their families for that period of time. We're talking huge distances here. If you're from Wick and you're going to the Royal Jubilee, it's going to be just, you know, you're almost asking folk to go to a different country. My concern is that if your waiting time guarantee stops when you've been offered an out-of-board appointment, what steps are you going to take to monitor the length of time people will wait? Because people are normally used to being treated within their board area and dealing with those distances that they travel.
Can I first of all say, obviously in the Highlands and Islands, particularly in the islands, much of the treatment is, particularly the more complex operations, is in any case out of board, because the Western Isles would normally orientate towards Glasgow hospitals and the Northern Islands would normally orientate towards Aberdeen. So a lot of that area in any case is already out of the board area.
Just on that point, that's correct, but they are often allowed to take a carer with them and have reduced fares and the like. That's not the case for Highland.
Well, obviously it has to be a reasonable offer. You know, the word reasonable comes into this as well. And if somebody is unable to travel to another board area because they need to take a carer with them, and for whatever reason the carer, that cannot happen or it's not being offered, then that would not be a reasonable offer if it's not being offered, clearly. It has to be a reasonable offer, and the reasonable offer has to take in those kind of extenuating circumstances within reason. But at the end of the day, what we're trying to do here is to try to ensure that the referral time for treatment, from referral to treatment, is a maximum of 12 weeks. And the whole thrust of this is to work with the patients to try to ensure that that happens. Now, there are occasions when patients themselves, for whatever reason, will make a decision that, for example, they don't want to go to Edinburgh to have the procedure done within 12 weeks. They would rather wait another 2 or 3 weeks and get it done in Raigmore. Now, we've looked at the analysis, and I think I mentioned this at my last appearance at the board at the committee in another context, and that is, if you look at beyond the 12 weeks and look at the 15 weeks, those who are not dealt with within the 12 weeks, 99% of them are dealt with within the 15 weeks. And I think people will make that choice. But, you know, at the end of the day, we are the National Health Service, and I think right from day one we've made it absolutely clear that where you have pressure in one board area, then the treatment time guarantee will apply to using facilities elsewhere in the National Health Service in Scotland. And I think that's a reasonable proposition in return for the 12-week guarantee.
Will you be monitoring where that happens? Because I'm quite concerned if this is in legislation, that those people will not appear on statistics as having breached their 12-week guarantee because their time will be stopped. And I understand it's good to get people treated quickly, but I also have a real concern that this may be kind of a backdoor option for letting people wait a long time.
No, if the patient hasn't had a reasonable offer for the treatment within the 12 weeks anywhere in Scotland, then that's a breach. If, however, we say to a patient, look, we can take you at the Golden Jubilee for your cataract operation, we won't be able to do it within the 12-week period, say in Raigmore, and the patient refuses that, then that is not a breach, because we have offered the treatment within the 12-week period in terms of the legislation.
And you won't be monitoring that?
We do monitor it, yes. That's why I can tell you the figure that's within 15 weeks is 99%.
It won't be considered a breach, so you won't be monitoring the people who feel unable to go away from home, who want a local appointment. You won't be monitoring.
No, we monitor it all. We've got the statistics, Rona, for every eventuality. I mean, we collect the statistics in such a way that the data can be cut many, many different ways, including that way.
I feel a raft of PQs come in on.
Just write and ask me what you want to know, and it'll save you going through PQs.
I also feel we're morphing into the debate rather than focused questions, but I think there were reasonable points you had to make, Rod, absolutely. And Richard Lyle, do you still have a supplementary on this?
Cabinet Secretary, can I just clarify something, a comment that Dr Simpson made a few minutes ago? He said it would be the board who would decide. From this, I take it, the patient will make the choice. This will actually give the patient more choice and actually more control. So it will be the patient who will decide who they want to get their operation, who they want to get their operation from, and it will all still be counted, unlike the comments that have been made a few minutes ago.
Well, I don't want to go down in quoting Mrs Thatcher when she said she'll have the operation when she wants it, where she wants it, and done by whom she wants it. Because, quite frankly, if we ended up with every patient taking that attitude, then, quite frankly, we probably couldn't meet a 30-week guarantee, never mind a 12-week guarantee. But I think where there is a reasonable request from a patient for reasonable reasons, that they want the thing done locally or they want to done by a name consultant, then we should try to accommodate that. But the quid pro quo is that we can't do it always within the 12 weeks. If we can do it within the 12 weeks and meet that request, of course we would do that. But there's no you lose the guarantee of the 12 weeks if you make that decision.
But at the end of the day, it's the patient. We are
The patient's choice. It's the patient's choice.
Yes, this amendment is for the patient's
Absolutely.
choice, not the board's choice.
Absolutely. In this case, it's the patient's choice.
Thank you.
Just hang on, Richard, just hang on, Mr Simpson, a second. If it's a focused question to the Cabinet Secretary, I will take it, because there's an opportunity for any points you wish to make in a debate which is still to follow this. So is it a question to the Cabinet Secretary?
Just to get further clarification, the note that we've received, the policy note, says before agreeing to the requests for specific practitioner or specific locations, the board must take into account the patient's health and well-being and whether it's reasonable and clinically appropriate to offer an alternative appointment. This is to ensure the board's policy and planning for delivery of services are not negatively impacted. So the patient doesn't have an absolute choice. The board still has to make a decision as to whether it's an appropriate. Is that correct?
Yes, there is that caveat. Obviously, I mean, if it's going to have a major impact on service provision, because we've got to think of all patients, not just the one making the request, obviously.
Yeah.
Then, but I think that would be very few and far between, I have to say.
Oh, thank you.
Thank you. I see Gail Patterson's now indicated.
Just a technical question. It wouldn't be for debate. Just to understand, if a person is made an offer and they don't accept it and feel that they've got a situation where a better outcome for them would take place, so the board would write to them and say that here is the offer, and here's the consequences of that offer. In other words, the time period is going to be extended to maybe 15 weeks. Does the person then, when the letter comes in, must that individual confirm they accept that condition? Or the fact that the health board has written to them and pointing the consequences, that's a done deal?
It's really a done deal. I mean, we're not requiring the patient to write back to confirm, because by that point, the patient will have already indicated to the health board that that is their preference.
What I'm getting to, Cabinet Secretary, is when they then understand that there is a time lapse, do they need to confirm that they accept that time lapse, or is it just a fait accompli?
No, they don't need to. What's the legal position?
Cabinet Secretary, if I could just assist. It's a sort of a staged process. So it begins with the patient not accepting the original offer, and then the board has to make a decision about whether the patient's health and well-being justifies making an alternative. And part of that whole process is that the patient has to accept that there's going to be a period that won't count towards the waiting time because there's been a change of either consultant or hospital.
I understand it now. Thanks very much. That's clarification.
Thank you very much. Are there any other questions on this point? Okay. Thank you very much. We now move to agenda item 4, which is the formal debate on the affirmative SSI, in which we have just taken evidence. Can I firstly invite the Minister to move S4M 09336?
I so move, Convener.
Thank you very much. And can I invite members, should they wish to contribute to the debates? I am somewhat surprised after the thirst for questions to the Cabinet Secretary. So let me just indulge myself by raising two debating points which I thought were interesting from the questions raised. First of all is this Parliament has, of course, just passed the Public Bodies Bill in relation to, or now Act in relation to health and social care integration, and I thought it was a really appropriate line of question that my colleague Rhoda Grant had in relation to what is a reasonable offer, and to make sure that carers assessments had been done and that carers were supporting individual patients to be able to travel to wherever the offer was made. I'm hoping that health and social care integration means that will happen more seamlessly, and it's less likely that there will be inappropriate offers. So I think this might be an example of government working in a joined up fashion. So during the debate I would like to put that on the record. And I think the second thing I'd like to put on the record is there is quite a differential between urban and rural areas, because in Glasgow, and I know this because we looked at this in detail in the Public Audit Committee when we looked at the management of waiting lists and waiting times and guarantees, was that due to a variety of reasons at Glasgow's Western Infirmary, the Health Board identified that waiting times and pressures in the system were starting to build up, and they put surgical capacity into the Southern General Hospital to mop that up. Many patients decided that they would vote with their feet, or not, as the case may be, and decided no, they'd wait for their named consultant and they'd wait for their surgical procedure at Glasgow's Western Infirmary, despite the Southern General, in geographical terms compared to choices that rural patients have to make, literally been just down the road. So I think it's important to realise that there is a geographical split in relation to what expectations of patients are in terms of what a reasonable offer is. And I also maybe put on the record at this point that the big issue for Greater Glasgow and Clyde Health Board was not that that was happening, it's that the 13 different computer systems, and they weren't recording properly what was happening, and hopefully that has been resolved. So I thought, given that none of my colleagues were seeking to use this opportunity for have a debate, that I would put that on the record, Cabinet Secretary. So have I sparked any other contributions to the debate, or is there any other members wishing to contribute at this stage? I see that they're not, so therefore can I ask the Cabinet Secretary whether he wishes to sum up?
I don't think it's necessary. I think I've said, hopefully explained the situation articulately.
Thank you very much, Cabinet Secretary. Can I therefore put the question on the motion? The question is that the Patients' Rights Treatment Time Guarantee Scotland Amendment Regulations 2014 be approved. Are we all agreed? Yes. Okay, I thank members for that, and I thank the Cabinet Secretary and his officials for their attendance, and we'll suspend briefly to allow you to depart. Thank you. Can we commence once more and move on to agenda item 5, which is also subordinate legislation? We have 5 negative instruments before us today, and the first instrument is National Health Service Superannuation Scheme Scotland Amendment Regulations 2014 SSI 2014-43. There has been no motion to annul, but the Delegated Powers and Law Reform Committee has drawn the attention of the Parliament to the instrument, and details are in the papers you have before you for this morning's meeting. Assuming that there are no comments from members, if this is the case, is the committee agreed to make... First of all, are there any comments from members? My apologies. Okay. Well, there being no comments from members, is the committee agreed to make no recommendations? Yes. Okay, thank you. The second instrument is Personal Injuries NHS Charges Amount Scotland Amendment Regulations 2014, SSI 2014-57. Once more, there has been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on the instrument. Are there any comments from members? No. Okay, there have been no comments from members. Is the committee agreed to make no recommendations? Okay, speaking with one voice. The third instrument is the National Health Service Optical Charges and Payment Scotland Amendment Regulations 2014 SSI 2014-61. Once more, there has been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on that particular instrument. Are there any comments from members? I should say my briefing says, assuming there are no comments, but I've led with this committee to assume nothing. So there being no comments from members, can I ask if the committee is agreed to make no recommendations? Yes. Okay, thank you. And the fourth instrument is the Carers Waiving of Charges for Support Scotland Regulations 2014, SSI 2014-65. Once more, there has been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on that instrument. Are there any comments from members? Okay, there have been no comments from members. Is the committee agreed to make no recommendations? Yes. Thank you very much. The fifth and final instrument is the Community Care, Joint Working, etc. Scotland Amendment Regulations 2014, SSI 2014-66. There has been no motion to annul once more, and the Delegated Powers and Law Reform Committee has not made any comments on this particular instrument. Are there any comments from members? Okay, so on this occasion, once more, there being no comments from members, is the committee agreed to make no recommendations? Okay, that is agreed. Thank you. So before moving on to agenda item 6, can we suspend briefly to allow the first panel of witnesses to be set up? Okay, can we reconvene the committee? Before moving to agenda item 6, can I intimate that our convener Duncan McNeill had given his apologies, but it was remiss of me not to mention that at the start of this meeting, and I would like to put that on the record, and that Nanette Millen MSP had intimated that due to unforeseen circumstances she was going to be slightly late for today's meeting, and I hadn't put that on the record, so my apologies, Nanette, for not doing that. I consider that rectified now. Moving on to agenda item 6, which is our long-awaited e-health session. So we're going to have 2 evidence sessions this morning, and can I first of all welcome our first panel. So can I welcome Dr Margaret Worski, Director of the Joint Improvement Team, Eddie Turnbull, Head of e-Health in the Scottish Government, Peter Williamson, the Lead for Health and Innovation, the Quality Unit, and finally Alistair Hodgson, Partnership Improvement Officer, Joint Improvement Team, Scottish Government. So thank you for joining us this morning. Now, we are going to move straight to questions, and I believe Aileen MacLeod has a first question.
Thank you, Convener, and good morning. Now, the area of e-health was identified as one of the committee's priorities for its European-related work, particularly given the range of EU policy initiatives and European funding programmes that are supporting digital health technologies and solutions as a way in which to promote healthy and active ageing through personalised care. And indeed, this is also an area that has been obviously identified by the Commission as a key priority in its Europe 2020 growth agenda, and one in which it not only accords closely with achieving the Scottish Government's 2020 vision, but it's one where Scotland is recognised as being at the forefront of European and global research and development. And as the committee's EU reporter, we were keen to explore with you this morning how the Scottish Government is engaging with EU digital health policy initiatives, the contribution that Scotland can make and is making in this area, and the potential for further engagement and the opportunities arising from such engagement. Now, a fortnight ago, we had a very helpful debate in the Chamber around some of the issues and challenges that we face, not least in the need to upscale our current efforts and the financial investment that will be required to assist the development of new capacities so that we can ensure that, for example, when it comes to the new local health and social care partnerships that are being provided for through the Public Bodies Bill that was passed by the Parliament a few weeks ago, that these partnerships will be able to deliver healthcare on a larger scale in communities across Scotland, and also in terms of ultimately improving outcomes for people. So the first question I wanted to ask was the extent to which that you see there being an opportunity to lever in new sources of European funding, as well as through the various EU-level digital health policy initiatives, and the extent to which these opportunities are being grasped. And in that regard, I'm thinking of things like the eHealth Action Plan. We also have the third European Health Programme post-2014. There's Horizon 2020, which that research and innovation programme also identified health, demographic change and well-being as one of its policy priorities and societal challenges. And there's also the European Structural and Investment Funds, as well as the cross-border cooperation funding. And I'd be interested to know is how we are prioritising digital health through the Scottish Government operational programmes.
Okay, thank you, Aileen.
Okay, I think I've been identified as starting off, and then I'll get colleagues to contribute. From my perspective as Director of the Joint Improvement Team, we've been working very closely with our colleagues in NHS 24, Scottish Centre for Telehealth and Telecare, really to sort of help support the opportunities in Europe and in turn look at how we can pull out the learning and share the learning in both ways. I think building on our success in achieving funding for the United for Health and Smart Care funding initiatives with our European partners, that's currently covering 7 health and social care partnership areas. And I think our success in achieving that funding was predicated on our ability to demonstrate that we were working in partnership, that we were integrating across health and social care. So the funding application really needed the buy-in of all our sectors, including our non-statutory sectors. So that's very much work in progress, and I think some of that has been showcased in Europe as we go forward. We've also been working very closely with our Scottish Government colleagues and with colleagues within NHS 24 and our wider partnerships on engaging in the European Innovation Partnership for Active and Healthy Ageing. And we're very active in the 6 areas there. I think you'll be aware that we also received 2 lots of 3 stars in terms of our reference site application, which was showcasing our National Telecare programme, which ran from 2006 to 2011, but also our work on anticipatory care planning. And we also are recognised for our falls prevention. So while that doesn't attract with it any specific funding, what the reference site application obviously does is to position Scotland well in Europe. And we're particularly mindful of the Horizon 2020 bids, and we have in the region of 10 bids that we are connected in with, 7 being sort of focused with NHS 24 and the Joint Improvement Team and the Scottish Government. We're also aware that some partnerships and areas in Scotland are also looking at how they build their capacity to put in for bids. So I suppose that's drawn together, I think, some of the very practical work and tangible evidence around our engagement in Europe, and I suppose the priorities, particularly within the Health and Social Care Directorate, but my colleagues can speak wider than that, in terms of ensuring that this agenda is working across policy areas, and we're seeing evidence of that in terms of trying to mainstream this agenda across our policy areas. But I think importantly, and particularly from the Joint Improvement Team's perspective, is really focusing very practically on building that infrastructure so that we can look for the opportunities and build that capacity and capability going forward.
Would any other witnesses like to add anything to that?
Just one point on the question of how it relates to our overall Scottish Government activity. I would say, I mean, there is the danger that you do just chase the money, and because there are hundreds and hundreds and hundreds of potential projects out there across Europe, some of which are are really closely aligned to what Scottish Government wants to do, and some of which are completely different. So we are being very careful that we do have that collective approach to ensure that any bids that we do put in are very, very closely aligned with the overall Scottish Government priorities, especially around 2020. So we are certainly very aware of that.
Aileen MacLeod comes back in. Anything else to add in relation to that?
I was going to say that our focus has very much been on those potential projects that will make a difference in terms of shifting the balance of care. That's where the focus has been. It's not necessarily been on what you might call the core e-health infrastructure, although we've of interest in that particular area around standards and integration. So it's not that we're blind to what's happening elsewhere in Europe, but the focus has absolutely been around where the money can make a real difference.
Thank you. Aileen, do you want to come back on
just,
that?
Thanks very much, Convener. Just on that, obviously, I mean, one of the projects is obviously around the international consortium bid that's been driven forward by the University of Edinburgh around the need to establish the European Institute of Innovation and Technology, Knowledge and Innovation Community in the area of healthy living and active ageing, which is known as the Life Kick. Now, there was a previous bid, I think in 2009, by Edinburgh University for a kick in the area of the Future Information and Communication Society, which was unfortunately narrowly failed, but which the government did support. And I just wondered what work was being done to support the Life Kick in the Scottish Government, and what benefits that you see this could bring, especially through, for example, something like the Digital Health Institute, and in what way the government could help support efforts in that regard to obtain European funding through such a Life Kick bid.
We're working very closely with some of our colleagues in the Life Sciences Division who are leading business and innovation. We are certainly aware of the previous bid, and one of the reasons that is positive as to why that wasn't necessarily successful, because it was recognised in Europe as probably the strongest bid, but the lack of success, if you like, was attributed to actually the member state buy-in, as in the UK support for that bid, which is why we've been very careful this time to try and position it as not just something that's been led by Scotland, but something that's been led by Scotland in partnership with the rest of the UK to get that support. And through, we actually meet now on, I think it's a monthly basis. We have a small steering group within the Scottish Government, but chaired by Edinburgh University, by Professor Mark Parsons, with Stuart Anderson, and we're very careful that we do try and build up that support both within the Scottish Government, but crucially also within the UK Government, which I think will be where this, I think, is make or break type situation. How that actually turns into something successful the next year, I'd say we're at the very early stages of that initial engagement. Up until now, the focus has been on building the collaboration and partnership across Europe and actually getting those co-location nodes, as they're called, aligned with the Edinburgh University aspect of that. So I'd say over the next year or so, that's very much where the focus will be on that engagement, both within the Scottish Government and the wider UK Government as well.
Well, I'm going for supplementary on that with you, Dr. Simpson, on that. Okay, let's see if I can take any politics out of this whatsoever, because that's not the reason for asking the question. You mentioned that there wasn't buy-in from the UK Government, particularly in relation to the health kick bid, which could have been the strongest bid on the table but didn't quite have support. Can you give any details, maybe one for ministers rather than yourselves, details of how the Scottish Government and the UK Government work constructively on these things to make sure that any bid that comes forward from this place dovetails with the UK Government? Can you give me some details in relation to that?
I don't think the previous one, I can't actually remember what the previous kick bid was in. It wasn't health specifically, if I remember rightly, but I was certainly before my time as to why that necessarily didn't work, and I think Stuart Parsons and Mark Parsons and Stuart Anderson here later on, I think they'd probably have a better idea as to that particular issue. Okay, I'm sure we'll do that. Thank you. Dr. Simpson?
Yes, just one quick comment. I'm glad we're leading on B3, which is the integrated health and social care. I mean, that fits with the general programme, and that we're clearly engaged in well engaged in some of the other European issues. But I want to look back. I know that some of you may be, as we speak, being involved in trying to produce the response the Cabinet Secretaries said he will make to my speech in the 2020 Vision debate the other week, which was mostly highly consensual and very positive. But I am concerned that as we go forward, as a leader in the whole area of telehealth and telecare, that we make sure that what we've got already is actually functioning to an adequate level. And so my question is just one of the I think some 8 or 9 areas of concern which I raised, and to which we'll get a detailed answer to the Cabinet Secretary, but that is the one of resilience, because we did choose to go down quite correctly a much more fragmented approach than England, which frankly wasted a huge amount of money on their big bang, let's solve it all in one system, and which has clearly largely failed. There are some gains, but not that many. Because we've got this fragmented system with 14 different boards all being able to produce their own systems within a set framework, we have actually ended up with problems which are clinically important. And I just wonder how we're going to solve those. But also the main thing is, do we have systems in place which are resilient? Because if they break, as we move to a paperless system or paper-light system, clinicians cannot afford to be without material of clinical importance for any time at all. And the breakdown that occurred in Glasgow could have been really serious. I don't think it was. It delayed a few things. But there's evidence from the FOI that I've done that there have been breakdowns in other boards, and the classification isn't even there in some boards. I mean, Highland reported 56,000 breakdowns. Well, they obviously were reporting every telephone conversation to IT, which was ridiculous. So what is being done about integrating our systems? Just one final comment. The Chair mentioned the 13 systems in Glasgow, and I know they're making good progress on this, but it's not just the within-board systems that need to be integrated, it's the across-board systems.
You raised 2 points there. One was the resilience, so if I'd maybe take that first, and the ability of the systems to actually be there 24/7, 365. So that'd be, and the second one is about integration of services. So I see these as related, but two different things. On the resilience piece, yes, there was the issue in Glasgow, and the root cause of that is still unknown. But just to go back to that particular point, the manufacturer of that Active Directory software has it on file and is monitoring for a similar failure worldwide, so that they can actually gather some more evidence in that. So yes, there's a frustration that we don't know the root cause of that particular incident. But we do agree as we move forward, and we're looking to have a very paper-light, if not totally electronic health service, we really do need to consider the resilience of our systems and how we deliver that. So that is a key plank of our strategy as we move forward. As a result of the incident in Glasgow, the Cabinet Secretary did initiate an independent review of the boards, and that was undertaken by NCC, a recognised expert in this area. And it did find, and that report is actually in SPICE now, I believe, so you can actually look at that. But it gave us confidence that actually the boards at the level of looking after that particular type of failure were well placed. They were given different sizes and boards, they were adopting different methods to do that. But nonetheless, they were well aware of the catastrophic failure that could be caused because of that point of failure. The second level was about general ICT resilience and thinking about the impact on services. Generally, should IT be unavailable? And again, the report found that the boards were very cognizant of this and had processes in place, again, commensurate with the size of the board. Clearly, what is in place in Glasgow is quite different from maybe what's in place in the Western Isles. But again, there was a due heed to risk and planning around the resilience of IT. But the report did find actually that we could do more in terms of joining up that IT resilience piece with overall business continuity, and there's recommendations in that report as to how we take that forward. And you'll find the report quite interesting because it's very aware of not the present, but what things are going to be like in the future, and we're obviously planning along those lines. It maybe gives me an opportunity to link into the resilience piece as well, because the integration piece as well, because part of what we're promoting is more regional working, but across boards and looking for shared services. So, for example, Orkney and Shetland are about to implement, or will this forthcoming financial year, implement TrackCare PMS, but they're not implementing it in their own sites. What they're doing is using the shared service from Grampian. So that builds in an element of resilience and integration there. So, as I say, it's very much work in progress, and we need to up the pace of it. We appreciate that, but it's very much in our plans going forward. So that, I think, addresses the resilience point. Integration, again, I concede the point that we could be more integrated, and again, that's a key plank of our strategy as it currently sits, 2011 to 17, and it will continue to be so as we refresh our strategy moving forward. We have made great progress in the last few years around using portal technology as the basis of making information available in one board that is actually held in another board. But again, in a roadmap of integration and need for interoperability moving forward, the Cabinet Secretary gave the commitment that by 2020 every citizen in Scotland would have access to a personalised health record. For that to happen, underneath the surface, our systems need to be more integrated, and we need to build services that work similar to what's in the private industry around how information is presented. What we're not building is a single one database holds all approach, as you alluded to at the start. But what we are doing is seeking and identifying the key points of integration that will enable the clinician to get the single view of a patient who maybe passes through a number of boards in that care pathway, and ultimately so that a patient gets the view that's appropriate for their condition. So it could well be that a patient who maybe suffers from multiple conditions maybe has to get access to a diabetes system and another specialty system, but still will have the core needs that everyone in Scotland would have to access core information. So we're building towards it, and it's very much part of our plans. But we've achieved quite a lot, I would suggest, up to this point.
Do you want to come back
Well,
on?
I wonder if other...
Yeah.
Let's just want to go with this.
Just to add to that, I mean, I think the issue of resilience is obviously also around how we address some of the infrastructure challenges more generally, and that includes our workforce. So there is work being progressed to develop an approach to technology-enabled learning, and a board has been established to try and really link this strategically with our workforce developments. There's also on the telecare front, we're working closely with our colleagues within the Telecare Services Association around standards required, and we've also had some recent dialogue and some joint working with the fire service around connecting up information and alarms, and how we ensure going forward that there is sort of reassurance that the systems are there and standards are being followed. I think on the telecare front, and in Professor Crooks can probably expand on this, but there's certainly an ambition that we can move from analogue to a digital platform, and we're working closely with colleagues in Sweden on that in terms of the opportunities that brings. So again, trying to look at, say, building the infrastructure around our system, and linked to that is also, I think, the citizen-facing platforms, which the Living It Up, the Dallas programme that's been funded through the Technology Strategy Board, Scottish Government and our enterprise colleagues. Again, I think sort of is exploring that capacity building around our infrastructure and use of mobile technology. And again, the video conferencing, which has been quite a success story, certainly in health, and it's looking at how we can expand that across some other areas such as criminal justice and local government. So I think there is a sort of particular issue that the Glasgow highlighted in terms of the IT technology and resilience, but I think there is a broader resilience that goes beyond the technology, but I think covers the wider spectrum of telehealth and telecare. So we need to really focus on that and build that infrastructure, as well as keeping our eye on the innovative opportunities, but we have to do both.
Thank you, Dr. Risky. Any other witnesses wish to come in?
Just, I think, to emphasise what Dr. Warisky's been saying, that there is obviously a crucial question about resilience of health systems, but I think the potential for service user-facing technologies is also something which is going to be challenging in terms of resilience, because they could well interact with health and other systems. But I think our view is that in the longer term, the opportunity to put the user much more at the centre of connecting to services rather than being connected with is the way forward. But I think that opens up significant challenges in terms of resilience of systems and just indeed the infrastructure of systems.
Dr. Simpson, do you want to come back on
I think
that?
I don't doubt the challenges facing us partly as a consequence of the way we built it up. There are significant challenges about integrating things, and that's, you know, I'm not being critical of that particularly, but I think that certainly being able to access laboratory results at the centre of a managed care network, if you happen to have them done in an area out with the managed care network, far less within it but in a different board, you know, these sort of basic things are fairly, I think, are fairly important. But I think I'll leave it there just now. I should say, Chair, I should have made a declaration, as I did at the beginning of my speech the other week, that I have 2 family members who are intensely involved in this particular area. So I need to say I have a family interest directly in this, in many of these areas.
I believe you have just done that. Thank you very much, Dr. Simpson. Nanette Millen.
Thank you. Sorry, I'm interested in I've been reading the papers we've been given, and the study or the project was commissioned by the UK Department of Health into the whole system demonstrator on the impact of telehealth and telecare. And I know the findings of that study are currently being looked at, and there's seems to be one very positive finding, that telehealth is associated with lower mortality and emergency admission rates. But there are 1 or 2 negatives that are being flagged up that concern me slightly. One was that for patients with long-term conditions, telehealth doesn't seem to be, from the study, a cost-effective addition to standard support and treatment. So I was hoping it would be. And telehealth is as implemented in the whole system demonstrator, didn't seem to lead to significant reductions in use of health and social care services over the 12 months that we looked at. And the final one that I stood out at me was that telehealth as implemented in the evaluation didn't seem to improve quality of life or psychological outcomes for patients over 12 months. These are all things that I was hoping would improve with telehealth and telecare. So I'm interested in your comments on that. I know it's early days, but I'm interested in your comments on that, and, you know, what can be done here to try and ensure that it does achieve these particular outcomes.
Who'd like to respond to that?
Yeah, I can take certainly some of that. We are obviously very aware of the whole system demonstrator. For those of you not necessarily aware of it, it was the world's largest randomised control trial into telehealth and telecare. The headline findings were quite remarkable, actually. I mean, the reduction in mortality rates you referred to was a 45% reduction in mortality rate. I mean, these were quite startling findings, actually, along with 15% reduction in A&E visits, 20% reduction in emergency admissions, 14% reduction in elective admissions, and a 14% reduction in bed days. So the headline findings were very, very encouraging from a technology perspective. I'll deal first with the cost-effectiveness aspect of it. One issue that we found with the whole system demonstrator, and indeed those involved in the whole system demonstrator themselves were very aware of, is the fact that they didn't necessarily redesign the whole service around telehealth care. There was a control group, and then there was the group that had telehealth, which was still getting traditional services and telehealth care in addition, which is where the extra costs came in, because the service was not redesigned around the use of the technology. It was very much as an additive to it, which is why the costs were greater. And that is one thing we've always been very clear of in Scotland, is that we do not want to see telehealth as an additional service. We very much want to see it as part of that overall package of care that is delivered to those who necessarily benefit from most, as and when it's appropriate. And the other challenge as well around reduction in use of services, for example, one thing we found in some of our work is that just because you have COPD, for example, doesn't mean that telehealth is suitable for you. It's not suitable for every single person who happens to have a common illness, for example. It's only suitable for those who have very specific parameters, which is why we're very clear this needs to be something that is locally led. We cannot just say that, okay, this is what you've got, therefore this is the standard approach that we're going to give you across the country. It's got to be tailored to that individual and built around that individual, which is where the personalised healthcare comes into it and the access they get into it as well. I can't really comment on the psychological aspects of that because it's not one of the papers that I have in front of me. But certainly we are aware of those challenges that whole system demonstrates. But I would say as well that every single area in the whole system demonstrator have now mainstream telehealth care. So the very fact they clearly saw the benefits themselves and have transformed their own services locally. So I would say, if anything comes out from it, that to me is the biggest message, that those involved in the study saw the benefits as being great enough to actually implement locally.
You comment on that, Mr. Williamson?
I think just to reinforce a number of points, I don't think of itself telehealth care is a solution. It is only when it is integrated, meshed with other service changes, that it will make a difference to people, whether that's a psychological condition or whether they have to go into hospital. So you made the point, I think rightly so, that this is early stage, and I think one of the challenges now is to find more effective ways to use the technology in and around people's care, whether that's healthcare or social care. And I think that's an ongoing position that we will see for several years. I think we will get better at it, and I think the important point is very much trying to design it around individual needs in a personalised way, rather than just saying, well, here's a bit of technology, we'll plug it in and everything will be fine.
Dr. Horace, did you want to come in there?
I think just to add, I think the point, I mean, the British Medical Journal publication last year, again, sort of gave some mixed findings around telehealth care, but I think one of the big messages coming out of that was that, again, the effective targeting of telehealth care is really critical in terms of where it sits within that broader care pathway. So, it has been proven to be really beneficial, but if you apply it en masse, you will get this sort of range of effects. We're also minded, I think, to ensure that certainly the work we're doing with our European partners and the Living It Up, we've built in from the onset sort of fairly robust evaluation. And we're also working with our local health and social care partners, particularly with some of the initiatives that were funded through the Change Fund, such as the Dalmellington project, which the Cabinet Secretary does refer to on many occasions. But again, it's building in that sort of evaluation, both the quantitative evaluation, which is around measuring what difference is made around emergency admissions or clinical interventions. But I think also the important point, I think, that you raised around the psychological and the qualitative aspects of people's quality of life and their own sort of self-reporting. So again, I think that's work that we do need to support and encourage local partnerships, even where they're embarking on some small-scale work, that we build in and share the learning. And we're doing that both within Scotland, but we're also obviously doing that with our European partners and further afield.
Thank you, Nanette. Do you want to come back on that?
I actually, to be honest, found the papers a little bit difficult to get my head around because there seem to be so many strands to this, that, so much happening in pockets all over the place, and I presume eventually something that might all come together, and clearly it's an important way forward. Do you think, in the fullness of time, we've done an awful lot in this committee, looking at things like access to medicines and appraising the impact of medicines, the cost effectiveness. Do you think in the fullness of time we need to be looking at telehealth and telecare and having a proper formal appraisal system at these services? I mean, I presume it will be some way down the road, but I suspect that something would have to be looked at fairly carefully.
I think the answer is yes, but again, I would stress, I think if you're just evaluating the technology, you're missing an absolute trick here. So I think it almost falls back into progress with a 2020 vision, outcomes for patients. I think these are the things that matter rather than simply, as I say, a bit of technology is being plugged in and therefore everything's hunky-dory. So I think it needs to be in that wider context.
I think what I would say would be helpful would be when you're scrutinising and looking at a range of areas, it would be helpful maybe to include as part of your questions what role and contribution is digitally supported technology. So with unscheduled care or delayed discharge issues, just the conversations you were having before around subordinate legislation, around waiting times and so on. So I guess the trick is trying to integrate it in the way we do our business, so also in the way the committee does its business, how you can begin to sort of explore and inquire around the role of technology in terms of support to the health and care arena, I think would be helpful. We also have our national delivery plan, which was launched really early last year. So it's a 3-year delivery plan. And again, I think that's providing an opportunity to look at some of the key priorities. But, you know, again, the committee may be interested going forward in looking at progress against that as we begin to sort of pull out some of the learning and the evidence. It is a bit iterative, but I think it's about how we include it as part of our exploration and inquiries.
Mr Turnbull, did you want to come in there?
Nothing to add.
All right, sorry, I thought you were catching my eye to come in there. That's fine. Nanette?
That's fine, thank you.
Okay, thank you very much. Rhoda Grant?
I think, well, my question is surrounding how we get this rolled out. It seems to be that we've been talking about this for decades, and it still comes down to the enthusiasts who are pushing this forward, and it doesn't seem to be totally integrated into the way we deliver health. How do we push that one further step to integrate it properly into the way we deliver healthcare?
Mr Williams?
Yeah, I think you're right. I think that's an important question of rollout, spread as we call it. It's back to the point I think we're just discussing, which is if telehealth and indeed telecare is seen as some separate entity, it will come up against or will cut across the grain of services. So we're now, I think, very committed to the idea of almost having a bottom-up demand for this rather than a kind of top-down technological driven approach, which is as people under the 2020 vision, shifting the balance of care, improving outcomes, begin to look at redesigning and transforming their service, the question that needs to be kept asking, will technology help you to deliver these kind of changes? And I think that will generate momentum almost bottom up, which will, I think, see it spread beginning to happen more rapidly. And I think that is something that we will have to do more and more of to encourage uptake in a way that's going to be positive and not just that it exists to use it. And I think the other thing we have to be mindful of is that technology isn't always the answer. That being able to link with somebody does take them out with face-to-face contact, and for a lot of people, social connection, etc., remains very important to their health and well-being. And the more one can offer people opportunities. So again, I think it's about being clear where the technology will make a difference, but equally where we maybe need to steer away a bit from that.
Any other witness in how we drive change, Dr. Horiski?
Yeah, I think a very important question, and something I'm sure our colleagues who are going to give evidence after us will add to. I suppose there's 3 things I'd like to draw the committee's attention to. I think one is that we are now currently engaged in some at-scale programmes. So we have moved really in the last few years from small projects. So the United for Health and Smart Care and the Living It Up are quite large-scale programmes. So I think that's first and foremost. I think secondly, we have our national delivery plan, and associated with that we've developed an improvement framework really to look at the whole rollout and improvement capacity and capability. And the third element of that, I think, is really supporting the knowledge exchange around this. So again, the large-scale programmes very much built into that is not just the knowledge exchange within those participating areas, but we have a good bit of Scotland now covered between the Living It Up and the 2 European programmes. So we're working with our local partnerships and wider stakeholders around knowledge exchange, and that also links to the knowledge exchange coming from Europe and us feeding in our good practice there. So as part of the work we're doing on integration and supporting implementation, we're having a sort of arm of that which is really around the improvement around this agenda, and particularly the European Scottish links to try and build that capacity and capability.
Mr Hodgson, do you want to come in there?
Yeah, it's just one other thing. I think adding to those 3, I would see the technology itself as being a big driver, actually, because if you think about it, 5-6 years ago, nobody had a tablet computer, and now I think in the UK it's something like 27% of the population have a tablet computer. So, and the same with smartphone coverage. It's gone from a standing start to, almost everybody who actually investing in a new phone, it tends to be investing in a smartphone rather than, your classic wee bricks. Obviously there are differences in that. And And one of the things that we're very keen to push through the likes of Living Up is the use of those familiar technologies. So it's not just saying, here's the health service, here's the technology we're going to give you, and this is how you're going to support it. It's actually looking at how we as a health and social care environment can actually encourage the use of the individual's own technology to support themselves. It might well be that we provide them with something like, a heart monitor that attaches into their own technology and feeds back. And the other big bit, because obviously then there does then become aspects of access in terms of connectivity, especially in some parts of the country where broadband connectivity is smaller or access to internet is much smaller, which is why we're also investigating how we use digital televisions. Digital television coverage is about 98–99% coverage in Scotland, so people have digital TVs. So it's looking at how can we deliver services through these platforms that already exist in people's houses, and that's where you end up getting that upscaling, because you're not having to invest in the individual televisions for these people. You're just investing in the back-end structure to actually send the information out. So again, I think the advances in technology, which is to an extent consumer-driven, is significantly aiding us in our ability to actually upskill this and become normal practice.
Just before I let you back in, just so that other members know, Colin Keir's got a supplementary in driving change, and then Richard Lyle's next. There are no other questions so far, so please catch my eye if you wish to ask another question, Rhoda.
Just thank you for those answers. I wondered if we're doing enough around training. When we're initially training medics and the like, is there enough training on kind of digital technologies, e-health and the like, so that people then kind of hit the ground running with an expectation that this happens?
Very much conscious of that, and working with NES, they are developing a technology strategy around the workforce. So that's something that we're very cognizant of. And I wanted actually maybe a link to the last point to bring in. You were asking about rollout and what the barriers might be. I believe one of these sits around information governance and perhaps the fear to share data, and as reflected in the recent Caldecott re-review, where we should be thinking not of the dangers around sharing, but the benefits that come from that. So I just wanted to bring to the committee's attention that we're trying to clarify that landscape, so that as there is more widespread use of digital technologies, the barrier isn't one of misconception around what can and can't be shared. Absolutely, patient confidentiality is paramount, so that will be built in. But we want to make sure that there's clarity around what clinicians and individuals can feel free to share in a joined-up, digitally enabled environment.
Any other comments on that? No, okay.
Sorry.
Mr. Hodgson.
Yeah, it was just on the technology-enabled workforce. I mean, that's almost got two strands. It's it's actually providing access to training, so that people can do their own personal training where and when they want it, rather than having to go back to base and actually allocating a specific time to do that training, because sometimes that's just not possible, even if it is desirable. So we've got to provide that kind of modular platform access so people can access the training as and when they want it. But it also ties into how they actually use the technology. And that's the existing workforce, but we're also cognizant of the fact that our emerging workforce needs to be able to come in and fully aware of this. So we're now part of the undergraduate curriculum in several nursing degrees. We're involved in several social work degrees as well. We're in discussions with some of the universities around the medical degrees as well, as to how we actually train up our future doctors. But we also have to be aware of the fact that the younger generation are very much, by and large, digital savvy, so they're bringing those skills into the workforce anyway. And it's about how we can actually turn what they do in their daily practice into their working lives.
Right, but we do have another supplementary, Richard. So no, but now Colin's before you in a supplementary. Rhoda, is there anything? Okay, Colin Keir.
Thank you. Just you were talking earlier on about the effectiveness in certain circumstances about something hadn't been designed to take in e-health, if you like. The whole system hadn't been redesigned. It's really, the question I have is, are you coming across any difficulties in any sectors who are less than enthusiastic about the concept of e-health, if you like, which is slowing the process down.
Any resistance?
Yeah, anybody out there who doesn't like the idea of going over completely to the technological side?
As you would imagine, I couldn't say that you could pick out any particular sector or group, but you know, individuals will have their preferences for ways of working, and as you introduce technology, you try to ensure that it's moulded to the way that the individual works, but equally the individual has to change practice to some degree as well. And we have found, as we've rolled out, for example, the National Track Care Solution and clinical portal, the take-up has gone up and up and up as we've introduced it, but variably within boards, just depending on their own local circumstances. But I think the eventual situation is, if you take the clinical portal, we now have 55,000 clinicians in Scotland accessing the clinical portal. And I go back to when I first joined eHealth, there was some reluctance around this, you know. So, you know, once something is in place and people see the benefits, they're soon wedded to it. In fact, following Dr. Simpson's comment, you know, on integration, I think they want more now, and that's our challenge.
There was actually a question asked in another place a few years ago when this was coming out, and there appeared to be some degree of resistance, and it was really an update on that, if you like. Is it becoming more acceptable? Because the concept of e-health 5 years ago, for instance, maybe wasn't quite as well known.
Yeah. So no, my opinion is that it's now very much embedded within acute and within general practice. There's probably more work we can do around community, absolutely certain there, but yeah, I think it's a positive story.
Okay, now, the Dr. Simpson, because, I mean, Mr. Lyle's been sitting very, very patiently for a long time now, and supplementaries tend to drift on to other areas, so I think I might take it in order of people who haven't spoken, which would be Mr. Lyle, then Mr. Patterson, and then to yourself, Dr. Simpson, with your indulgence. Okay, so Richard.
Thank you, Convener. Medicine has evolved, technology will evolve, and I'm going to show my age. Remember a programme that used to be on Tomorrow's World, and many of the things that were shown on that programme have now came about. And I remember actually seeing for the first time in America my first digital TV, which was, you know, the thin ones, were about £6,000 then, which are now down to, but even buying them for 400. Can I turn to a point you made earlier, Dr. Waworski, and Peter Williamson touched on it, national video conferencing, and the point that was made earlier that, in particular, Highlands and Islands, I know that in the papers we've got over 60,000 video calls are made every quarter. Work's underway to expand access within the NHS into other parts of the public sector and into people's homes, as you said. Basically, I note that in one case in the Highlands and Islands that there was a situation where a child was seen by the basically a paediatrician and saved the child being transferred hundreds of miles to a place from their home to a hospital. The use of the video conferencing allowed the uncalled paediatrician to hear and see the child, which aided a more accurate diagnosis than originally suspected, and the child was then treated appropriately in the local hospital and then discharged, whereas previously a transfer by air ambulance would have been required. So technology, wonderful thing, must improve, will evolve. Basically, you know, and it sounds futuristic, but the future actually is today and tomorrow. And basically, the situation is that, do you believe that video conferencing is being used more, especially in the faraway outlying areas where it's not possible for people to go to a general hospital?
So should we do more video conferencing?
Yeah,
absolutely.
I'll start and maybe Mr. Turnbull will come in. Absolutely, and I think again, the way we do our business, I mean, in terms of not just clinical work, but obviously the way people conduct meetings now, we're beginning to sort of all rely a bit more on technology and in our social interactions using Skype. So I think the technology is becoming more every day, and I think there has been quite a significant growth in people's confidence and ability to use video conferencing. There was some anxieties around, the distance between the patient and the professional. But I think, again, where it's established in a way with proper protocols, with local staff on hand to, make sure the person feels it's a personalised consultation as opposed to something that's been done sort of very impersonally. The feedback from both the clinicians and from the users seems to be very positive. And also there's been some good examples where it's been extended into some of the care homes in more rural and remote areas. So we've got some good examples of dementia, psychiatrist being able to video conference in, provide advice and assessment to a care home, again avoiding a very traumatic transfer of people, from the islands or from very remote areas into the sort of main psychiatric establishment. So again, as people are using it and gaining sort of confidence and patients are becoming familiar, certainly all the feedback I've heard from presentations has always been very constructive. But again, you may have something to add.
I could say that we're monitoring the use of video conferencing both for meetings within the health service and for its use in terms of clinical engagement, and the figure moves up quite rapidly. I think that's based on two things. Just as Margaret was saying, a more confidence in terms of that engagement and how that works from the clinician's point of view, but also is due to the resilience of the service that over the last few years we've, rather than having a series of disjoint video conferencing capabilities across the board, we now have one national service. And I think it was alluded to earlier that other sectors in Scotland are now looking to build upon that service. Alistair mentioned earlier the digital broadband rollout, which again will bring more use of VC. So I really do see it as a technology that's obviously well understood. And actually, the barrier in that is once we have the connectivity, is not the technology. Again, it's the service change around it. But I think it's going to be a real boon as we move forward.
Thank you, Mr Turnbull. Richard Lyle, do you want to come back in?
No, that's fine. I've received the answers I was looking for, and drive forward.
Yeah. The future is today. Mr Patterson, Gill.
I don't think it's too profound a statement to make that you have two barriers normally in anything, and that's change itself as a barrier and cost. I mean, I think that NHS 24 proves that we are very much over the barrier when it comes to the public, and what you've already been saying, that the system that we're developing and the personnel involved in it are engaging and engaging well. But I wondered when it comes to the actual cost, and I think an element of what you're suggesting is preventative spend. You spend the money in technology now and you benefit in the future. But I wonder what your views are. Is there evidence, I don't want to lead you, but is there evidence to suggest that it's not preventative spend, that we're getting an immediate benefit in what we're rolling out? Is there evidence to show where it's having an impact so that we can it's not safe for saving's sake, I would think this committee is looking for. I think we're trying to achieve the same as the government, to save money to spend more in the health service and shift it to some other elements of the health service.
I think some of the evidence we have would demonstrate that it is providing sort of here and now alternatives to people. Certainly some of the research and evaluations that have been done around the telecare of people with dementia and other sort of dependency needs has demonstrated a delay or an avoidance of a care home placement that would have happened, an avoidance of an emergency admission. And we've also seen some examples where if you can embed the role and contribution of telecare in particular as part of discharge planning and get it part of that early assessment, then it can facilitate earlier discharge from hospital because there's less risks. People are less risk averse. So I think there is evidence that we are addressing some immediate sort of interventions that the alternative would have been hospital admission or a care home admission. I think the challenge with all of it is, you know, it's part of this bigger picture about shifting the balance of care and supporting more people to be as independent and as well in their own homes for as long as possible. And the work that we are supporting partnerships in terms of their joint strategic commissioning, which is really looking at the next 3 years, but taking a 10-year horizon, is how do we redesign our services based on our assessment of need, you know, the resources we're spending, and so on, into the sort of services that are going to achieve the outcomes. And the challenge will be in how we shift the resource. You know, how do we shift the resource from where we're spending it to where we need to spend it in alternative ways?
I think,
Mr. Williamson?
yeah, I think a lot of what we've seen around e-health, telehealth at the moment has been substituting a current service for an existing service, and often with positive benefits, patients not having to travel, admissions being avoided. But I think moving forward, the opportunity to connect with people and intervene earlier, use monitoring, digital connection and monitoring equipment, etc., will allow this to move very, I think, strongly into the field of preventive care. So I think the potential is there. As this rolls out, there will be greater and greater opportunities to offer opportunities for clinical staff and others to monitor patients earlier in the process, and therefore hopefully prevent the onset of crisis and breakdown more often. So I think there are great opportunities here.
And Mr. Turnbull, did you want to comment?
Echo that. I think we have made great strides in finding extra capacity within the current service from introducing IT. You know, so another example I would give you is the use of digital pens, which you've probably heard of in a number of boards, but originally in the Western Isles, where the community worker was simply given an electronic device that allowed them to record information at the point of care and not have to continually return to base to enter that data. So in effect, time saving, but eventually giving that individual more time to spend with the people that they're delivering care to. So I was just going to say that, so our focus has generally been, I do agree, within the service and looking for that efficiency that it gives us increased capacity and the ability to reinvest. So part of our e-health delivery plan, which every board has, a key plank of that is that efficiency, and we do monitor the money being reinvested into improvement. But to concur with my colleagues, you know, it's more than that now. It's about holistic service change.
Gail, have you anything to?
Yeah, that tends to back up what the Cabinet Secretary told us, that in some of the pilots that we could see almost immediate benefit from telehealth. So, and Mr. Williamson's already drifted in to my second question, that what's the potential for the future? Will it answer some of the problems that we've got in relation to a fixed budget or a budget in the health service that goes hyper when it comes to inflation compared to other areas? Does this address some of these problems? Is this something we can look forward to using telehealth? Will that, by effectively finding people early, like Mr. Williamson said, finding people early, treating early, so in the long run you spend less on that individual and redeploy?
I think the answer to that is absolutely yes. How far? We will discover in the course of time, but without any doubt the potential's there. And it's not just, I think, the potential to monitor people earlier and stave off crises. I think it is also the opportunity for people to connect more readily with services. And that's the other side of the coin that we need to be. As we were saying, 98% of the population have a digital device in their home. That can be used very effectively to connect with services in a variety of ways, and that can make it easier for people to access advice, etc., etc. So a lot of potential. What we're not clear, I don't think anybody is just how far it will go.
Any other witness want to comment? Mr. Hodgson?
I think it just goes back to the point I made earlier about the consumer drive as well, because I know you're hearing later on from the Digital Health Institute, amongst other witnesses. They went to the Mobile World Congress in Barcelona a few weeks ago, and they're saying that every single mobile manufacturer in the world is looking at healthcare and how they can embed that into their devices. You're already seeing, for example, the latest iPhones, the latest Samsungs, they can already monitor your heart. Can you imagine what these devices, and obviously these are high-end devices, but you always see stuff that's in high-end devices eventually filtering their way down to low-end devices. So what we have now in the really expensive equipment, in 5, 10, 15 years' time, will be in every single person's pocket. So there will be that consumer expectation that they are monitoring their own health, their own well-being, and that the health system can respond accordingly. So now is the time that we are actually having to enact to actually enable that change within the system, so that when these devices become bog standard, which they will become bog standard, then we are fit and able to actually respond to that demand at a local level.
Bill?
Thanks very much.
Now, before I bring in Dr. Simpson, Mr. Lyle, this would have to be specifically on the immediate benefits of the use of e-healthcare, or else we'll take you after Mr. Simpson says on the immediate benefits.
I'll wait until Dr. Simpson's.
Right.
Sure.
And Mr. Lyle, I think you'll be the last question. Okay.
One of the political issues that we've got at the moment is the fact that the proposed care data system in England is not only being criticised by many clinicians who need to have confidence in the system, and Mr. Turnbull referred to the growing confidence in Scotland in using systems, but clearly there is quite a degree of public concern. Indeed, there is a campaign, and care data has been stopped for 6 months. Now, I know with Spire we have a different system, but are our witnesses today confident that we can continue to carry the public with us as well as the clinicians? And what are we doing to ensure that we actually identify the fact that our system is not that system which is being criticised?
Mr. Turnbull, yeah.
You asked, am I confident? Yes, I am. I think we've approached this, I think, in a completely different way from down south, which I think has been the right way. We've involved patients in the construct of Spire. We've involved clinicians in that approach. We've designed it around a way that absolutely guarantees the confidentiality of the information. So I think the Scottish way, if I might put it that way, is to think of things through carefully, and it's around engagement, and it's around that incremental approach. So I'm confident that we'll reach a point of where we have the Spire system actually providing great benefits around the use of that information, which will be held confidentially. In terms of the communications approach around that, we are again working that through at the moment. So it's work in progress.
Any other witness want to comment on that?
Just, I mean, it's related, but it's not so much about the sharing of information for researchers and care data, but it's also just the sharing of information generally for the benefit of the individual. And around that sort of lack of engagement, if you like, that happened around care data, we've taken a complete opposite approach with our Living It Up programme. Whereas we've been out, and it's only involving, at the moment, 5 health board areas and their local authority partners. But we've been community engagement has been absolutely at the forefront of that, and to date they've spoken to over 8,000 members of the public, whether that's through just pop-up stands in shopping centres, for example, or going to the local community centres and actually going out and doing that engagement. And the feedback that's come from that is people very much expect their information to be accessible in whatever form to the health and social care. They also expect to have that communication channel between themselves and the professionals. But the one thing I guess that engagement exercise has shown us is just the value of engagement, apart from anything else. And I think we can feed that back into almost anything that we want to do. Is actually, when you go out and engage with people, generally speaking, it's overwhelmingly positive when you're actually having that proper discussion first, rather than just imposing something that they necessarily don't understand.
Dr. Simpson. So, Mr. Williamson, did you want to come in there? Or sorry, Dr. Simpson.
I wanted to give our witnesses the opportunity to put that on record because I think we have got a different approach. It is engaging the public, and that's important. But as the witnesses will also know, I still have concerns about the tracking of access to records. I still see this as an area which is potentially could be a problem. And the Fife episode with accessing Gordon Brown's records, for example, was just one bit of it. We only have a retrospective system of access. We don't yet have an audit trail which the patient individually can access to check who's accessing the data. And looking at the breaches, Lothian has the only area with an effective system in place of even retrospective checking, and they had 260 breaches last year. So I just wonder if we're on top of that, you know, because we don't want to ruin what is effectively a really good system in Scotland by having cases come out where there have been breaches or the patients feeling that people are accessing the data when they shouldn't do.
Turnbull?
Dr. Simpson knows we have a programme of rolling out retrospective audit around who has accessed which particular records, and there is a target in our e-health delivery plans. Each board has a target in there to have that in place by 2015. So we're monitoring that situation quite closely. Going forward, we have not decided on the policy around an individual's access to see who has accessed their records, or the method by which we would address that. So I concede that's something that we've got to think about.
Thank you.
Thank you. And we'll give the final question of this session to Richard Lyle. Thank you
just
for your patience.
a comment in regard to the point Mr Hodgson made. 30 years ago, things that we thought weren't possible, we now can actually walk into Boots and buy a monitor to check your blood pressure, etc. And I'm sure that will happen. But on the point Mr Turnbull made earlier on, out of hours doctor service, they now are supplied with laptops to walk into people's houses to check their records, etc., rather than just walking in with a piece of paper. Yes?
The out-of-hour service has access to digital access, as others do, to the emergency care summary and the key information summary, so they can get access to medications information. So, yeah.
Thank you.
Can I now break my own rule, Richard Lyle, because can I have a very, very brief supplementary on that? You mentioned out-of-hours doctors having access to emergency care summary information. Apologies if I get the terminology wrong. If an older person presents in hospital and via A&E and is admitted to a ward, should we expect that ward to have the social care plans that are in place for that person and a variety of other details of whether there's home helps or care assistance or a morning service or a tuck-in service or meals on wheels, because obviously a care needs assessment is one of the core things that nursing staff have to do in that situation.
There is very limited integration at the level that you describe. I mean, clearly that's something that we need to work on. We're focusing on, you might see the interfaces between the services at the moment. So in terms of discharge, we're well aware of the issues around delayed discharge. So there's a particular focus in that area. But as for having a fully, visible by all set of information that's relevant to care and health in a combined sense, that I think there's some way off that at the moment. But we're working towards that.
The opportunities are there.
The opportunities are in fact there, yes.
And I have to say, I've now sparked a final question. So not just the final question, but the final question for Richard Lyle.
Oh, but the answer, and I've not come back. No, but basically, would it be good if we all carried about a card that had our medical history, that we could just go smart card, that would just go, like your, as you get into any, I'll not mention a national food chain, but any food chain, you could just walk in and go beep, and that brings up our history for the future.
I'll keep it very brief. There are examples. Let's link this to we were having this conversation in terms of Europe. So that there are actually examples in Europe where that is the case. We are looking at that. It is not something that we enable at the moment or have in our immediate plan over the next year or so. But we're certainly looking in that direction.
I'm not advocating it. I know a UK government was talking about these sort of things and that would have cost billions of pounds.
I have to say, I think
it's just the future.
Yes, well, yes, indeed, it's just the future. I was hoping to give Mr Turbo the last word, but my colleague Mr Lyle got it. There we are. Can I thank all four witnesses for your contributions today? It's very, very interesting. It's something I'm sure we'll follow up on in due course. Thank you. And can we suspend briefly to rearrange the table and for a brief comfort break for members? everyone, thanks for coming along. We'll get started. So can I restart the Health and Sport Committee meeting at agenda item 6, which continues on from our previous evidence session. So we move to our second evidence session of the morning, this time in a roundtable format. As usual with a roundtable, we traditionally go round and everyone introduces themselves rather than me reading out your names. And so I'll start off. Bob Dawes, MSP for Glasgow and Deputy Chair of the Health and Sport Committee.
Francesca Giannini, Scotland Europa.
Rhoda Grant, Highlands and Islands MSP.
George Crooks, I'm Medical Director in NHS 24 and head the Scottish Centre for Telehealth and Telecare.
Aileen MacLeod, MSP for the South of Scotland.
Justine Ewing, Chief Executive of the Digital Health Institute.
Annette Milne, MSP for North East Scotland.
Professor Mark Parsons, Associate Dean for E-Research at the University of Edinburgh.
Richard Lyle, MSP for the Central Region.
Brian O'Connor, the European Connected Health Alliance.
Gil Patterson, MSP for Clydebank and Mulgai.
I'm Bill Templeman, I'm the Strategic Lead for Digital Health for Scottish Enterprise.
Colin Keir, Edinburgh Western MSP.
Stuart Anderson, School of Informatics at University of Edinburgh.
Richard Simpson, MSP, Mid-Scotland and Fife.
Frances Mayer, Head of General Practice and Primary Care and Institute of Health and Wellbeing, University of Glasgow.
Okay, thank you everyone. You're most welcome. Now, before I go to the first question, it could be quite challenging given the numbers to get everyone in, but I am going to give priority to the non-MSPs here. So plead to MSPs, myself included, to be focused where we can on our questions, and we'll try and give as much time for the witnesses to get your comments on the record. So can we open with a question from Aileen MacLeod, MSP?
Thank you very much, Convener, and for given with the time constraints we have as well, I'm going to try and roll some of the questions I want to ask into one. Obviously, there's been, as I said in the previous session, there's very clear recognition within the EU of the potential of the digital health sector as a key driver for delivering significant benefits to those who rely on health and social care, as well as for providing new avenues for economic growth and also on job creation. So I wanted to ask, what scope do you see there is for further development of Scotland's role as a leader in digital health and care in Europe, and where also you think the new Digital Health Institute fits within that? Now, I'm particularly interested to hear a bit more about Scotland's participation within the European Innovation Partnership on healthy and active ageing, and also in terms of the opportunity within that for the exchange and learning of best practice, how we're planning to utilise the new European structural and investment funding programmes and the cross-border cooperation programme, as well as the Horizon 2020, to help us scale up initiatives and also to build the research and innovation capacity through the smart specialisation strategies in the area of digital health, and also just in terms of the Life Kick bid, to ask maybe perhaps what more we could be doing both as a committee and as a parliament to help support that bid at a Scottish, UK and European levels, and perhaps Professor Parsons, who's here, can update us on where that bid is and what the timescales are that you're working to, and also just in terms of the benefits you think that will bring to not just with Scotland but also across with the EU as well.
Well, thank you very much for that, Aileen. Now, given the fact that Professor Parsons has been named, perhaps you could open up on that.
Okay, thank you very much. Thank you, Aileen. The EIT was established in 2008, really as a European response to the success of MIT in the US. And in standard European fashion, it's not in a single place. It delivers its benefits to Europe through these things called knowledge innovation communities. Scotland is leading one of these bids. It's called Life Kick. It focuses on their theme, which they've just called for in healthy living and active healthy ageing. It's a very large, complicated bid. It involves 6 co-location centres spread around Europe. Each of these is expected to set itself up as a centre that really acts on top of the research that's already going on and developments already going on in the region. And so if you think of companies and universities and in this case the health sector working together, the KIC tops up that funding around €10 million per year per centre for probably around 10 years. So it's a big bid, €600 million in total, we hope. Aileen asked specifically what should the committee and the Parliament be doing. I think that To date, we've received very good support in Scotland from engaged MSPs. We've been briefing both people in the Scottish Parliament and in the UK Parliament as well. David Willetts is very aware of this bid. What we need now, as we enter the 6-month period just before we submit the bid on the 10th of September, is when we ask for it, strong written support from the Scottish Parliament, so that we can say that this is a bid that's important for Scotland, for our universities and for our businesses and for the people of Scotland. I think one of the fascinating things about this bid is it's a network of European centres, and I'm sure Professor Crooks will mention this later, that Scotland's taking a lead role in Europe in this area. It's very, very important that we're seen to be doing this, and the opportunity that the KIC gives us is to show leadership, but also to learn from these other regions. I was in, very briefly, Bordeaux 3-4 weeks ago, speaking to the Vice President of the Aquitaine region, and one model they're experimenting with is that all the people who work for the post office will become people that go into old people's homes and check they're taking their tablets in the morning. And this is novel ideas that I think we can all learn from across Europe, and it's these sort of things that some of the powerful things that working in these big European networks give us.
Thank you. Now, if witnesses could get my attention, so I know who would like to speak. But again, it's almost as if you've arranged this previously, but Professor Crooks was just mentioned there, so...
It's not that we're rehearsed in any way. No, thank you very much. Just over 3 years ago, I was tasked by the then Chief Executive of the NHS in Scotland, Derek Feely, to actively engage in Europe to promote what we were doing in Scotland, for a number of reasons. Number one, as a number of people have noted around the table, we are recognised by the European Commission itself as one of the leaders in digital health and care innovation. And we need to actually trade on that, both to raise the profile of Scotland, because it can do two things. Number one, it can create opportunities for inward investment, bringing global technology companies into Scotland to work in partnership with our public services and with our academic community to address the challenges that we have in delivering health and care in a sustainable way for our citizens, but also to create advantage to our small and medium-sized enterprises. Now, as a GP of 23 years, the challenge of actually linking health spend, which actually we should regard, and as Brian will mention later, as investment, is really liberating for us, and I hope I'm helping you out. It is really liberating from a Scottish point of view, because we usually regard health spend as cost, and what people tend to look to do with cost is cut it. But it's an investment in our citizens. So for us, our engagement across Europe is really influencing a number of things. Because of our recognised position, we are now influencing the European Commission in its thought processes about future funding opportunities. And was said by government colleagues earlier, unashamedly we are looking to point them in the direction of the strategy already adopted by Scottish Government, particularly around about the integrated care agenda, which all European countries are now looking at, and we are certainly in the vanguard as far as that's concerned. But also how we actually transform care from being solely delivered to people by the public sector to actually our citizens, not simply taking responsibility, which is the wellbeing agenda, but actually feeling supported to deliver their own health and care through the appropriate use of technology. We did a very large public consultation exercise, and the citizens of Scotland told us a number of things which, one or two, surprised me. Number one, citizens of Scotland want to give something back. They want to give something back to their communities. They want to care for others, but find it difficult to do so, either because parents live at a distance away, or in fact because both partners are in full-time employment, they don't feel they have the time. And they like the sense of community. And they believe technology can help them in those things. They want to use technology, but they want technology to be simpler, and they want to be able to learn how to use it more effectively. And so our programmes are actually unashamedly designed to do just that. And our engagement in Europe allows us to learn from good examples across Europe, but also to share our learning with others. because we don't have the luxury, both in terms of time or investment, to design everything bespoke within Scotland. We need to actually take good examples, tartanise them, and move them into our service at scale. And my final point was the point that was just made. For the first time, we have got included within the Smart Specialisation Strategy for Scotland digital health as one of the key strands, along with some of the other things that we're recognised for, which is food and drink and renewable energies and so on. For us, that is really liberating, because we believe that it's not simply getting a mention in a document, but it's how we lever that to benefit our citizens. And if we can grow the economy of Scotland, we actually generate well-being. And that is often better than actually shoveling out tablets to our citizens.
Thank you, Professor Crooks. And I have to say, Mr O'Connor did catch my eye before he was name-checked by Professor Crooks. So, Brian O'Connor.
That's because George Crooks told me to make sure I followed him immediately. Right. I represent an organisation which has members throughout Europe from all sectors, academia, industry, government, health, etc. And the feedback that I would say is the external view of Scotland is that is one where it is clear that you've recognised the power of digital health, recognised the power of working together between health and social care. But what I would say to you is, and you may not want to hear this, but I'll say it anyway, is you must not become complacent. Now, you might say, well, we're not complacent. My experience going around Europe to many countries where we have ecosystems, as we call them, where we meet regularly with all of these different sectors, is that it is easy to get carried away with a little bit of success. I think you've had success and you deserve it. But as a critical friend of Scotland here, I would say the following. I think you need to focus much more strongly than you appear to do on the economic benefits of this. And if I may just for a moment just tell you of a piece of work we did last year in Northern Ireland, my home country. Up to 2 years ago, the Ministry of the Economy, as I call them, I think they call themselves the Department of Enterprise, Trade and Investment. I prefer economy. The economy and health ministers, though they were from the same party, didn't really see the need to have their departments work together. So we organised and arranged that there would be a formal MOU between the economy and the health departments. And when that was challenged by one of the agencies of the Economy Ministry as to why do we need that, we know everyone. The answer is, well, please name for me the client managers you have for the Department of Health. And the answer was, there were none. Why are there no client managers for something which spends so much of the government budget? And the answer was, well, because it's another government department. So the lesson we learned from that was, we produced a report last year, which I think is instructive. And as a suggestion to this committee, I realise you're the Health and Sports Committee, but there's a very big economic opportunity here. And that is that in Northern Ireland they spend £4.5 billion a year on health and social care. It's an integrated service. That represents 40% of the total public sector spend in Northern Ireland. That's bound to get anyone's attention. Many people were saying we should cut the budget. Our report revealed that that 4.5 billion employed 70,000 people, which is almost 10% of the total workforce in Northern Ireland. Then in addition to that, 3 billion of that went straight back into the economy through salaries and payments to doctors and dentists and so on. And the other 1.3 billion was actually spent on buying things, procuring things every year. The other 200 million was for capital spend. As a result of the simple declaration, that has now been, by the way, accepted by the executive in Northern Ireland, not just the two ministries, the annual investment of 4.5 billion is how it's referred to by everyone from Peter Robinson, Mark McGuinness down. That has created a complete change in the mentality and the culture and the way we look at healthcare. And as a result, we're beginning to attract jobs because people throughout Europe and the world realise there's a joined-up health and economic approach to this. So I would recommend that this committee, no doubt working with other committees, should at least consider sometimes the statement of something which is obvious, right? It's really important because the obvious isn't always obvious till you know it. So I would suggest to this committee that's one action you could take to consider whether there should be some, and there may be already, some formal overarching MOU which says we are going to work together It's amazing how that plays internationally when you're branding Scotland as a place which is joined up not only in health and social care, but in the economy as well. And the last point, if I may, quickly, is this. I don't know if you're any different from all the other countries in Europe, but one of the things that's becoming very clear as we travel around Europe is this. The more successful your policies, health and social care policies, are in Scotland, the bigger your risk of failure is. And by that I mean that in Northern Ireland and other countries, the big push is to keep people in their own homes, keep them out of hospital. If they're in hospital, get them out as quickly as possible and stop them being readmitted. At the lower end, and that's unfortunately the way people look at it, domiciliary care workers, as we call them in Northern Ireland, there's a shortage of them. The fact is, if you do not look after people, you're successful getting them in their own homes. If they go back on a revolving door into the hospital, believe you me, both politically, economically, and from a human perspective, that would be unacceptable. There therefore are, I'm leading a workforce skills programme in Northern Ireland at the moment, to identify how many additional jobs we need to fill, properly trained in the use of smart technology, properly trained in supervisory and managerial skills, because often those people do not have a career path. And that's why they leave when a corner store opens. They can get more money by stacking shelves in a supermarket than they can for caring, literally caring, hands-on care for people. So my suggestion is there might be an economic opportunity to create jobs and take people off a dole queue. But in addition, you will then stop that revolving door back into hospitals.
That's quite challenging, I think for the committee. So yes, we're at the vanguard of much of these activities. Yes, we're going out there at a European level and we're seeking resources, but don't be complacent about it. Are we really exploiting all the economic opportunities that exist as a business venture, as well as the health aspects of it, Mr. O'Connor? But also, are we doing enough to make sure we train some of our lowest paid care staff, who will have to be the people who are using a lot of this e-health opportunity? So two things they're thrown into the mix, saying, look, it's not all rosy. Yes, there's good things going on, but we can't be complacent. We have to move forward. Justine Ewing, do you want to come in?
Yes, please. I just wanted to touch on the point that was raised by Brian in relation to the opportunity that presents itself. And then probably just add a little bit in relation to the basis of how we're working. So the first point is that digital health now recognised as a clear emerging market, with the latest report that I could find stating that the global market will be worth 14 billion by the end of 2017, with a clear indication that Europe will hold the market or the lion's share of that split, specifically stating that 4.1 billion of that will be generated in Europe alone. So, not wishing to make any wild assumptions, but if you think about the opportunity that presents itself with Scotland having a leadership position, with perhaps 2 or 3 other countries being closely aligned, I would suggest that the opportunity is quite significant. Just to point, or to pick up the point that Brian made about working together, currently I'm actively working with digital enterprise and health and care directorates within St Andrew's House, and receiving a significant amount of support in relation to the activities that DHI are undertaking. And just to, I suppose, to add a little bit about DHI, DHI is about collaborative working at the front end. So that is about having clear and very specific understanding of the need and the opportunity. And I reference some of the earlier conversations in the earlier meeting around the potential for preventative care as well as monitoring. But the support for the agenda of digital health in Scotland is significant. And I certainly would like to just have that noted, that from our point of view, only being 6 months old at this stage, but the acceptance of the Digital Health Institute and the opportunity is absolutely significant.
Okay, thank you, Justine. Any other witnesses wish to come in? Mr Templeton?
So from a sort of economic development standpoint, I think we're quite unique in as much as we've got the demand side there in the NHS and care. if you like. People want to buy stuff and solutions to problems. We don't actually have that in many other sectors in Scotland, as well as the ability to innovate and very strong academic capability. So actually we've got three component parts to produce significant economic gain in terms of jobs outside of the NHS. And therefore, as when Justine and George and so on talk about the inward investment attraction, that's built on a reputation that would be built up over the last few years. We're actually now got very firm foundations to attract much more inward investment. And when we begin to speak as Mobile World Congress, you get that kind of buzz about things. Companies are coming to the SDI stand and saying, we would really like to come and talk to you about what we could do in Scotland, which is not something that generally happens with the intensity that we're sensing at the moment. And I think that's a really important thing about building the strength of the activity in Scotland. And the KIC itself builds on that and enables that significantly.
Thank you. Aileen will come back to you in a second. Francesca Giannini, do you want to come in briefly?
Yeah. Very briefly, because one of the points that Aileen made was what are we doing in Scotland to access to make the most of the European funding available. So very briefly, the Scottish Government is promoting a bigger support to Scottish organisations, and there is now an integrated service. So there is a group of organisations. So Scotland Europa is part of this group. We work with the enterprise agencies, so Scottish Enterprise, Highland and Island Enterprise, and the Scottish Funding Council, really to create an integrated approach to Scottish organisations in accessing European funding. Now, this group mainly focuses on Horizon 2020, which is probably the programme with the biggest budget available at the moment. But there is this view of promoting a wider engagement in Europe. So a few initiatives. We delivered a series of events throughout 2013 on specific areas, and 2 events focus on health. And e-health was addressed as part of that. And also Scotland Europa is now, together with Scottish Enterprise, promoting a sector mapping. So we're working with our colleagues from Highland Island Enterprise and Scottish Enterprise to identify where the opportunities are for Scotland to engage in Europe in more meaningful and strategic projects. And certainly e-health is an emerging opportunity. So it's a work in progress, and hopefully this is a part of this integrated approach to support Scotland in accessing European funding.
Okay, thank you, Francesca. Professor Anderson?
Okay, I was just going to add a little bit to what Bill said. And I think having the public sector involved in Digital Health Institute is really important because of regulation and because of deciding what not to do. I mean, we had this earlier when we were talking about telehealth being understood within the overall package of service that you see. And really, in order to innovate effectively, you need to make a big enough hole to fit an innovation into. And at the moment, what we're trying to do is cram telehealth into a very narrow hole of already existing services, and actually understanding that dynamic and understanding how you regulate and understanding how you actually decommission as you commission new elements in there is a really critical thing. And I think Digital Health Institute has that. I think the perspective from NHS 24 has that, and I think the enterprise agencies bring that as well.
Okay, yes, Professor Mayer.
Just one further comment. I think it kind of reiterates what Professor Crooks said about people needing to be fully supported. And when I hear a lot about telehealth and telecare, we hear about interventions for people with chronic lung disease, people with heart failure and diabetes. But here in Scotland, we should note that most people are multimorbid and have multiple chronic conditions. And my nightmare scenario is that I have my patient with heart failure, diabetes and COPD who has 3 separate boxes that don't talk to each other. And that's not something that I think is actually that far away, because I remember not too long ago the Wellcome Fund had an innovation challenge, and I asked them about putting in a bid for telecare for multimorbid individuals, and they said, oh no, you can't do that, we need disease-specific bids. And I just think in this, in the DHI, it'll be important to involve groups like the Alliance Scotland and groups who speak for patient representatives about those who are not just one condition, but multiple conditions, because everybody over 65 virtually is multimorbid in Scotland, and 40% of the whole population.
So whose job is it to join up these dots then? You're mentioning about using new technologies, but individual clinicians perhaps working in silos rather than joining together. Whose job is it to join up the dot? Is it the digital health?
I was about to say the missing link here that people haven't talked to. You talked about engagement and other barriers. I'm a GP for 25 years, and telehealth and telecare is totally absent in my landscape. I've always worked in more deprived practices. So when I worked in Liverpool, I was in Toxteth, and I'm now in Thornley Bank in Glasgow. So it's more mixed, but in the top 200 deprived practices in Scotland. And there is an issue also about the digital divide, because although people have smartphones, it's about use. So I always tell people, you know, about NHS 24 telephone CBT. And it's interesting the barriers you get when you talk to people, because if people usually have mobile phones, they say, actually, I can't make that call because it's an 0800 number, but because I'm calling for a mobile, I have to pay for it. And things like that. When I asked them about using the Living Life to the Full website, which is a great online CBT resource, so many of them are not accessible. So there is this issue about what George talked about supporting people and increasing their capacity to engage with that, because of course we're very aware, especially coming from Glasgow, about the inequalities and the disparities in life expectancy between the east side and the leafy West End suburbs. And I have a concern that there is this consumer drive, which I think is right, and not to hold that back at all, but that's the giving the haves and the more able the ability to drive that agenda, and to make sure in Scotland especially that we don't leave behind the have-nots. And I would say the GPs are central, and I've been asked before, we've done work that have looked to barriers and facilitators to implementing telecare for long-term conditions. And one of the things in general practice is the drivers. Obviously, since 2004, there's been the new GMS contract, which looks at the quality and outcomes framework, and GPs have been driven to a tick box exercise looking at chronic diseases individually. So now somebody with heart failure comes to the clinic to get seen by the practice nurse, and they come separately to get seen for their diabetes, and they come separately to see from their COPD. And we are trying to make inroads into that. In Glasgow and Clyde, they've made new, what they call smart templates for the local enhanced services, so that if you start populating one template, it populates the other, and we need to think more about that. But for GPs, telecare and telehealth is out there as peripheral business. It's not core business. It's something extra they have to do. And people talk about professional resistance, and I would say it's not professionals, it's almost like professionals are difficult. In fact, if you weren't ready to change, you wouldn't work in the NHS, because it's been perpetual change since I've been in it. But what you have to think is what's people's core business. And just now, when you look at policies and the way GPs get paid and the way that they have to, the tick boxes they have to tick, telecare and telehealth isn't there. So it's a peripheral activity until you make it much more part of routine work, core business. And you think GP practices are now 100% electronic records, so they're not anti-technology, because they can see that helps them get paid, it helps them do work. We use the portals now for referrals, so 100% of my referrals, I see a patient, they've got a breast lump, I can say, your referral will go off today, I'll send it, and they'll have it, and you'll get an appointment within 2 weeks. I have to still wait months to get the letter back from the hospital secretary, which is an amazement to me. But so it's not that GPs, for instance, and primary care is anti-technology. It's just it's not integrated within the service. So I think that's one of your... And 90% of healthcare contacts are in primary care.
Absolutely. Now I'm going to end. Dr. Simpson, you may have a follow-up question in a second, I feel, but I know Professor Crooks wants to come in just now.
Yeah, to answer your original question, is that following a discussion with Deputy CMO last week, the Scottish Centre for Telehealth and Telecare has got an integral role in taking this agenda forward and joining up all the dots that are on the table. But it is challenging, there is no doubt about it. And the issue is, why was IT adopted across general practice? Well, it was because there was time and investment put into that. And there were incentives for GPs to adopt technology. And just because something is a good thing to do, or actually even just because something benefits patients, does not mean that it will be adopted. So we need to take all the levers across the system and bring them together. But what we need to do is not have the scattergun approach about doing a smaller bit over there and a little bit over here and something over there. We need to identify one or two of the big ticket items that are real challenges to our health and care system just now, that we know have got an international evidence base where technology can make a real difference, and focus our efforts on 2 or 3 big ticket items and do that at scale. Now, we know simply that the citizens of Scotland want to make their appointments with their GPs online. But actually the vast majority of practices do not make that offer, although the technology is available today, should they choose to turn it on. Why is that? There are a number of reasons, which are cultural and things about control. But there are things that we can work, if we put a strategic plan in place, we can move that forward. So from my point of view, that is fundamental. But the other critical thing is that we need to recognise, and it was said earlier, that technology isn't going to benefit everybody. And we have got people who are excluded for a number of reasons. But that's not a reason for not doing something. That's a reason for making your plans robust so that you do include people. And we're working with the Digital Directorate within Scottish Government, looking at digital inclusion to work hand in glove with them. So to go back to Brian's point, it's the last point, Chair, and I'll be quiet, is that we are joined up. I chair the Digital Health and Care Innovation Programme Board, which is the oversight group that monitors the whole of this landscape. And around that table we have got government representatives from Enterprise and Digital and from Health and Care, from both our enterprise organisations, from the academic community. In fact, Professor Anderson sits on the group, as well as representatives from local authorities and health boards, housing and the voluntary sector. All of the key parties are around the one table to coordinate and drive this forward, because we can only do this in partnership.
Okay, any other witness want to come in before I bring in Dr. Simpson? I think so. Professor Mayer and Dr. Simpson. Then I'll take yourself, Gil. Okay.
And that was really a question for Professor Crooks. Yeah, that sounds a very inclusive grouping. So, are there clinicians on that grouping beyond yourself?
Yes, we have. We've got clinicians on that grouping. We also have now decided. We've now been given, SCTT has been asked to formally interact with the GP community, because we've got the 2020 vision for primary care and general practice in Scotland. Technology isn't mentioned in that document. It's fascinating. And general practice in Scotland is recognised as one of our most innovative sectors. So it is not that people don't want to engage. We need to actively sit down and get into that dialogue today.
Professor Mayer, do you want to come back on that before I go to Dr. Simpson?
It's fine, thanks.
Okay. Richard Simpson.
Actually, Dr. Crooks has almost answered Professor Crooks has almost answered my question, but it does seem to me to be absolutely fundamental that, a lot of the telehealth, telecare seems to link specialists to individuals, and yet it is primary care, and I should declare an interest as a fellow of the College of General Practitioners, but it is primary care that holds the reins on the integrated care planning for individual patients. And yet, as we heard in the first session, if telecare and telehealth is an add-on and not core business for general practice, we are not going to succeed. And we're going to continue to have this silo-type service. And patients don't want that. They want actually to be able to go to their clinician and say, what about this and that and the next thing, because they are integrated. And I've just experienced that. When I asked my oncologist about certain items, he couldn't even tell if there were side effects from other medication that I was taking, because it wasn't his field, it wasn't his area. When I asked the GP actually told me. But, so I think Professor Mayer's point is fundamental. This is the big flaw in what we've got at the moment, that in making general practice absolutely central both to this and to health and social care integration. If we don't do that, we will not succeed.
That's maybe a comment rather than the question. But
sorry, as usual, Chair, I'm sorry.
No, that's absolutely fine. I'm going to leave that hanging unless someone catches my eye. Justine Ewing.
I just want to add that I think that the one thing that is very clear in the Digital Health Institute is that the engagement of practitioners, regardless of whether it's health or social care, is absolutely fundamental. And you will not find any project in our portfolio that does not have that frontline engagement. And in fact, a project that we're about to announce in the next couple of weeks has got 5 territorial health boards and 5 GP practices in each of those health boards. So I think that the message is very loud and clear, but certainly from all of the engagements that we've had in the last year and a half of getting this ready and the last 6 months of being live, is that digital health and the opportunity that presents itself will only be successful if it can be adopted, if it can be scalable, if it's interoperable, and it's needed not necessarily wanted, but as long as it's needed, because that's what will address the big issues that we have in relation to finance and challenge that we have in the next 3 to 5 and probably much beyond that, but also the other opportunity in terms of job creation, company creation and wealth generation.
Any other witnesses want to follow up on that? Okay, Gail Patterson.
Can I just raise a question with Professor Mayer? My practice I've been in the same practice my whole life, which is probably one of the most challenged areas in Europe. That's the Milton scheme in Glasgow. That's where my GP is. So I was a bit concerned, or maybe more, not concerned, but interested in your view with regarding proceeding in the way that you think we're proceeding, and that we might leave behind a very, very challenged area like the Milton. Is your view that we should have two models, or do we need to find ways to engage with areas like that?
I think, as I say, I would agree with Professor Crooks that we're not about trying to hold back the advances and the people that want to push ahead, but it's really important that we have put into place mechanisms that we bring those who are in more challenged circumstances with us. People who have multiple health problems have a treatment burden, a lot of demands put on them by healthcare systems. And those from more disadvantaged backgrounds, especially those who do not have good social support networks, maybe because of drug or alcohol or other problems, will have lesser capacity to deal with those self-management tasks and to manage this and to try and think about monitoring their blood pressure or monitoring their sugars or whatever. So what we need, I think, is to make sure that we have systems that we put into place, that we use health and social care, we might use lay workers or other mechanisms to try and enable those people to bring them up and along with the kind of front runners, those consumers who are pulling the systems, so we don't leave them behind. And I think that has to be a really important part of the planning, as to how do we enable others. And I know that across the Dallas programme, which Living Up is part of across the UK, that groups, for instance, in Liverpool are using champions and lay workers to try and digitally enable others, and there's all sorts of mechanisms being trialled. But I do think we need to, along with being at the vanguard and going for EU funding, which is great, and we should do, is think about those challenges. And other European Union countries have those challenges. We work just now with partners in Greece, and their austerity measures have them particularly in difficult situations. And so we can share learning, again, across Europe in relation to how we deal with some of the challenges and how other countries deal with the challenges. But I do think that needs to be an important strand of it that's going along as part of that integrated e-health plan, is about exactly how we're going to enable those who are less able.
Any other witnesses want to come on? Professor Parsons and then Professor Anderson.
So part of the work I've been doing in LifeKick at the moment relates to the industry engagement, and that's got two sides to it. It's talking to a number of Scotland's small companies that very much the DHI deal with as well. But also what has struck me in talking quietly to some larger European companies is the whole sector at the moment has been described as the Wild West. So you've got these very large companies, all of whom believe they can do it all. And this is really one of the challenges, as you try and take these technologies and apply them in the real world with real patients, real GPs, etc. And I think Scotland is at the vanguard of this, but we do need to recognise that it's a complex area of technology, that it cannot be driven by the technology. It needs to be driven by the process change within the health service and the way that patients access those changes. That seems to me absolutely fundamental to all of this.
Okay, thank you. Professor Anderson?
I just wanted to pick up on something that Aileen said at the beginning, which was really about the role of the EIP and AHA, because that's kind of, we've not really touched on it at all, and I think allowing George to say a little bit about that would be interesting. But certainly from my experience of it, it really does bring together the whole of the European experience, and I think Scotland plays a very big role in that, and there's a lot of learning and there's a lot of exchange of knowledge goes on there, and I think it's extremely useful in terms of the European context and in terms of Scotland's role within that. But George can say.
I lead the Integrated Care Action Group of the European Innovation Partnership with my colleague Donna Henderson, and we've got over 450 individual members from 280 European organisations in 23 countries across Europe as part of that collaboration. and it looks at the totality of integrated care. So it's not simply looking at integration of health and social care, it's looking at vertical integration within health and how systems integrate. But I think what's equally important, and sometimes when we talk about technology, we always think about monitoring something, your blood pressure or your weight or whatever it is. But that technology should also, and in Scotland what we're saying, it needs to connect people to their communities. So in fact, go back to Francis' issue, that lots of people have got simple mobile phone technologies, 2G services. You can use 2G to do a huge amount of stuff. 3G you can do more with. But actually, if it helps someone with a very chaotic lifestyle to access services, not treat their drug or alcohol problem, but to actually give them some structure back in their life. And what we're very good at in Scotland is innovative service redesign. We invested a huge amount of time and effort training our middle and senior managers on service redesign. That's where our strength is. The ICT is designed to support service redesign, not to drive it. And sometimes we get carried away by the glamour of technology. It's not about that. It's about people. And technology actually is and what I say in all my presentations, this is fundamentally important. Our strategy is to use ICT to protect the most valuable resource we have, and that is face-to-face contact within health and care. It is most valued and it's most valuable, and we can make it more accessible through the appropriate use of technology. It's not replacing a social worker or a doctor or a physiotherapist with a piece of kit. It's not about that at all. But some people are concerned that's what it means, and in the Scottish context it is far from that.
Okay, I don't see any other of my MSP colleagues ready to ask a question at the moment, so can I ask one? It's more about two aspects of health technology innovation. There's things that the patient or the consumer or the resident doesn't have to see. It's the clever bits behind the scenes that makes things work more efficiently. But for the things that they do see and they connect with, who's asking the patient what they would like to change? Because I'm conscious that there's all these clever boffins thinking about clever ways to innovate, but who's actually saying what I represent Glasgow Milton, who's asking the person in the housing scheme in Glasgow Milton how they would like to see. And maybe this is happening, these are all good things that are happening, but it'd be important to put it on the record if it is happening, and if it's not, maybe get that on the record too. So who's actually asking the patient how they would like to see technology enhance their experience?
Well, it is happening, Chair. Is it happening as efficiently and effectively as it could? No, it never will. But you've heard around this table, it's been mentioned a number of times, Living It Up, which is an ICT-enabled programme. It is the largest co-production programme in Scotland, probably in the UK. It involves, at the moment, 8,000 of our citizens from across communities, be they deprived and be they very well off, co-creating and co-designing this service offering. 8,000 of them at the moment are designing this web-based service for us. And that is our model for the future. For far too long, clinicians have gone into a darkened room and designed services, and people should be grateful for what they get. And I'll hold my hands up, I was as guilty as probably all the other clinicians in this room who did that, because that was the way we did it. That's no longer the way. We can't afford it. So co-creation and co-production is what it is, and the Joint Improvement Team is working with my team within Scottish Centre for Telehealth and Telecare to actually drive that technology out there. And we're actually working with design experts. So Glasgow School of Art and Design, who are a key partner in DHI, are integral to this, because our academics designed the consultation exercise from day one. We didn't bring them in at the end to evaluate it. The challenge is Professor Mayer has got the task on behalf of Technology Strategy Board to evaluate how Living It Up works, and we'll stand or fall by that evaluation. But if you speak to the users, they actually really appreciate being involved, and they value seeing their input make a difference.
Professor Mayer, don't worry, I'm not going to come to you and put you on the spot in relation to that, but are there any other witnesses want to comment on that area? Mr Templeman.
To do work on Living It Up, we were very conscious that we needed to engage fully with the community. And actually, although many companies say they do this kind of thing abroad, they're not quite in the same league. They're not focusing on doing this kind of design-led activity in the same way as we are in Scotland. That's actually quite important, because it means that we are getting the right kinds of solutions for the right people in the right places. And George is right. We're still in the foothills. We've got a bit of work to do, but we'll get there.
Yeah, Brian O'Connor.
Just to say this, that it seems to me that I'm very interested in the response to the question, because I'm learning a lot about Scotland as I visit here more often. As I said earlier, you've got a lot of good things going, but it seems to me that we're not even utilising, in this sort of discussion, the technologies that exist already. Too many people think of technologies as something that's going to come, tomorrow. I'm struck by the fact that not long ago, one of my grandsons, who was 8-year-old at the time, wasn't feeling well and said to his mum, "But I really do want to go to school today because I've got a project." And she said, "You've got to see a doctor." So he handed her his iPad mini and said, "Can I talk to the doctor?" And she said, "No, why not?" And when an 8-year-old asked that, you have to find an answer. And the answer was, the doctors won't allow you to do it. So what I'm pointing out is, in another instance where a clinician in France, I think it was, didn't want to bring his patients back after operations, maybe a 3-4 hour journey each way, to see him for 10 or 15 minutes. And his local hospital authority and doctors would not allow him to use Skype, even though all of these people were on Skype. And if they weren't, their children would help them get on Skype. And there are barriers which are man-made. Perhaps in these days you say man and woman made, just to make a point. But the reality is there are things that you could do simply by looking at those simple things, which would then enable you to consult more widely and be more part of a citizen's life. And I don't think we just use the existing technologies, much less create new ones.
So there's a very specific, clear example. We've got all the kind of telehealth preeminent experts around this table. Is there examples of that kind of telehealth activity happening in Scotland already, or is it something that's being developed?
Yes, there are examples of it. Is it deployed at scale across the whole of the service? No, it's not, but we've got very good examples of that. There's a number of the follow-up appointments from the Golden Jubilee Hospital where people come at a distance for orthopaedic procedures. The follow-up happens using video conferencing links. And in the north of Scotland, where there's challenge of rurality, there are very good examples of remote clinics, both in terms of neurology, epilepsy management, psychological therapies, mental health, and so on. And one area that we haven't focused on is the challenge the NHS in Scotland has about providing health and care services into prisons and into custody suites. Digital technologies, particularly video conferencing, is one of the technologies that's been looked at by a number of health boards to enable particularly prisoners to access services in a confidential way and with dignity. Because the last thing prisoners want to do is to be taken with 2 guards and sometimes handcuffed to an outpatient clinic where everybody stares at them and looks at them as they go through the corridors in the coffee shop. They would rather be treated with dignity, and using video conferencing technology actually can improve the experience for everyone as well as create efficiencies within the system. So we've got good examples, but they are not at scale.
Thank you, Professor Crooks. Justine Ewing, you wanted to come in?
Yeah, I just wanted to pick up the point on patient engagement that was raised earlier. I think there's a number of things that we're doing, and it's just to give an example of how that engagement works. There's 3 different types of activity in DHI. One is about understanding need or answering questions that have no answers. And we're very clear that as part of the development of our, I suppose, concepts that may well move into finding digital interventions, whether that is video conferencing or something that perhaps doesn't exist today, users, and I use the word users to represent users of social care services, third sector, and patients, and indeed their families and circle of friends, will be involved at every step of the way of that. And in particular, when we're looking at replicating or prototyping things, we have something that's called the Experience Lab, and literally we have replicated hospital wards, bedrooms, GP surgeries, and really going through the entire process with, we call them actors, but they are actually patients or members of the public who've been through particular sets of circumstances and can evidence very personally and very clearly the impact that either technology has or does not have, depending on what it is that we're speaking about. And secondly, not wishing to replicate or spend money unnecessarily, we have already tapped into the Living It Up community and agreed with them that that platform of 8,000 users that are already actively involved in some of those programmes will actively be engaged in DHI activities as well. So I think there is a real strength in the capability that's been built there already. But I just wanted to make the point that I think that patient and user experience is critical because the ability to adopt these new types of services that are coming in are very dependent on will as well as skill to use this type of work.
Okay, thank you. Professor Mayer?
Talking about something else in terms about information exchange, and it came up in the earlier session, which was about barriers to information sharing because of governance issues. I was up in Inverness at the Centre for Rural Health because actually they were talking about their transnational EU-funded telemedicine service, and one of the projects they had there was an app where people with inflammatory bowel disease could put in their information about their symptoms and send it to the specialist nurse who could then take action if things went wrong. And I said to her, well, it's a very biomedical model you've got there because it's somebody taking down their symptoms and then sending it to the clinician and you never get any feedback. I said, why aren't you sending messages saying that looks good or graphical displays back? And they said, oh, well, because governance controls at Highland had said that they couldn't do that because in case it wasn't a secure pathway to send back information. And so that is something that I see. And of course, for GPs as well, email is something we could do with patients, but most GPs don't want to do it for, there's a variety of reasons, but one of the ones they'll put up is about confidentiality, and if it gets breached or hacked into is an issue for them as well. And I think it's not been helped when people phone, for instance, the medical to dental and defence unions and talk about telecare, telehealth, being told, oh, well, we're just waiting for case law to be made. And that doesn't help people's confidence and things, even though there really shouldn't be a greater risk from doing things in this way. So I think there needs to be a kind of move to look at some of these governance information sharing rules, which are there for good reasons. Again, I talk about data security, but how we can break down some of those barriers that actually stop innovation and integration and information sharing and more person-centred type care.
Dr. Simpson?
Yes, there are 2 points I wanted to make. One is Scotland has this system of managed care networks. King's Fund has said, you know, they don't know that they're highly beneficial yet. I'm a great believer in them. I think this cooperative, collaborative approach is vital. But you're often, you know, reaching out quite long distances, even in the central belt, and yet we're not using technology to actually link patients in. So you still have to travel, you know, 2 or 3 hours there and back for a 10-minute appointment, which quite frankly could be done by Skype very easily. So I think the point that Brian O'Connor was making is absolutely vital. We should be actually asking these patients who've gone through this experience, what would have made your experience better? Well, again, for me, it would have been that I didn't need to travel for 3 hours to see someone for 10 minutes, you know, which was a waste of their time and a waste of mine, frankly. Bigger waste of mine in this particular case. I think the other thing is that engaging the patients in terms of security. I don't understand why we're not using encrypted email. You know, certainly the email system I use can do encrypted emails to other people who are using that system, but it also now can do it to people who are not using the same email server. That I can put in something which is, you answer this question and you now get into my email. So, you know, I don't see why we're not actually giving that confidence to people. So I'd like our colleagues to comment on these two, you know, already existing, as Brian O'Connor quite rightly said, forget about all the innovation stuff, which is great and wonderful and everybody gets excited about it. Why are we not using the basic stuff we've got now in a system that gives us confidence?
Any takers on that?
I'm very happy to answer that. I absolutely agree with everything you've said. There are examples in Europe where email is used as a regular way for doctors to interact with patients, and the world hasn't come to an end in Denmark, for example, or Holland, where it's business as usual activity. Speaking to the chief physician within Kaiser Permanente in the US, when they went to digital consultation, which they did, there was a number of clinicians who thought they were going to be swamped with patients emailing with questions. What did it do? Nothing happened at all because people used it responsibly. People are very comfortable using email. People are very comfortable with a recognisable level of security, as you said, and that is available just now. But more importantly, Eddie Turnbull, if he was sitting around the table, would say that this is the bane of our lives, that the information security and information governance regulation is a bit like a black art in Scotland as it is across the whole of Europe. And people make things up. And people make things up and say things with such a degree of authority that we all believe it's true. And then when you look behind it, it doesn't exist. This issue about not being able to send an email to a patient, it is not written down anywhere that you can't do that within the NHS in Scotland. This issue about not being able to access video, there are issues with Skype about how Skype works and where it gets its server capacity from and so on. But there are a number of off-the-shelf, free-to-use video conferencing technologies there that are being used. For example, they're being used just down the road in Lothian. But if you actually ask in a different health board north of here, can we use the same thing, their e-health people say, no, you can't. And that is because of a lack of understanding rather than there being anything written down. We need actually to put simple Noddy's guidance out there to people to get rid of people who make up policy on the hoof because it either suits them or it makes them sound important.
Okay,
Did I just say that?
I'm certainly going to look forward to reading back the official report of this particular evidence session. We are... It's just getting interesting as we're drawing slowly towards a close. Can I make a suggestion? I mean, one of the things we'd like to do as the Health and Sport Committee is not just do a one-off, take the weather, take the temperature of where all this is. And thanks to Aileen MacLeod, MSP, who was keen to have this round table today. What's the best way, if we were to come back this time next year and do something similar, whatever we decide to do with the work plan, what kind of things should we be looking out to see if there has been real progress? I've put down, for example, well, we could track how much inward investment there's been in the next year. We could monitor, perhaps, how much new innovation there's been. We could maybe find a way of measuring how much there's been a rollout of good practice embedding existing technologies, such as Mr O'Connor was talking about. And we could actually, maybe more importantly than any of that, actually ask patients whether it's better met the outcomes that they need. And that's before we got on to the IT stuff and the Noddy's guide to whatever in terms of rolling out best practice. So my question would be, if we do return to this, how do we do that monitoring process? Is there any set framework that this committee could look at to say, okay, 1 year's passed, 2 years has passed, where are we with this? Is anyone aware of how we would seek to measure and scrutinise that going forward?
Can I make a suggestion, Chair?
Only because Justine Ewing did catch my eye first. Yes.
I was just going to mention that the work that we've been doing with our enterprise partners, in particular within the Innovation Centre community, of which I am one member of what will eventually be 8, along with the FAR Institute and a number of other organisations that are looking at the wider picture of digital health, which includes data and genetic revolutions, as well as sensors and microchips and all the rest of it. But there is a reporting framework being developed currently between the enterprise partners and Scottish Funding Council to track the developments, and particularly in relation to my area, looking at improving cost effectiveness, improving health performance and patient experience, quality of life, and then very specifically the economic measures. So there is the groundwork of something there that, without perhaps recreating and investing a huge amount of effort and money into something else, that could give you certainly a sense of what is going on in relation to this specific market, as it were.
Yeah, before I bring in other witnesses, I should say we are running out of time, so this would be your opportunity, I suppose, to have a final comment before we draw to a close. I know Professor Anderson wants to come in, and Professor Crooks as well. So, Professor Anderson.
Well, this is just very quick. It was actually to say something about what George said at the beginning. I think was very important, which is focusing on 1 or 2 large-scale initiatives is the important thing, and seeing what change happens there, and actually understanding those things that are actually happening at scale. Because one of the issues about is to confuse innovation with novelty. Yeah, I mean, I think I think the point here is to innovate, you actually have to bring something that gives you value. And that can be a bunch of stuff that's been around for 10, 15, 20 years. But understanding the integration and understanding how you build that ensemble is really what innovation is about. And so looking at it at scale in Scotland, I think, is the big thing to do.
Professor Crooks.
Great. We have a national delivery plan for telehealth and telecare, which was formally signed up by Scottish Government, COSLA, and the NHS in Scotland. And it has got defined targets annually over the next 2 years. So that is one way of looking at the agenda within Scotland. But there is one thing I would like to say, and it actually is directed specifically at this committee. The one reason that Scotland is where it is that we have had national consistency of policy in this area for the last 12 to 14 plus years. And that is because it has had cross-party support and consistency of approach. And that is fundamentally important in this kind of areas, because when you look at other countries that don't have that, where policy changes every 3 to 5 years with a change of party in power, it sets them back a huge amount. So Scotland has got a huge amount to commend itself, and in fact, this committee and in this place, that consistency of policy is something that we who are tasked with taking this agenda forward really do appreciate, because it makes our life slightly easier.
Thank you. Professor Parsons.
Two very brief comments. One was to comment on what Justine said. In the context of LifeKick, Scottish Enterprise are doing a piece of work at the moment looking at the economic and social benefits if we got the LifeKick funding. So it looks at the number of companies that would be created, the value generally to the Scottish economy. So that would very much feed into these indicators that you were discussing, and it's a piece of work that's already happening. So I'm very happy for that to happen. And the other thing to say is that we'll know by the time this committee were to happen again if LifeKick had been successful. But even if it isn't, the value of the network we've created around that will happen, whatever happens. Obviously, I hope it's successful, but it's very important, this whole process that we'll be going through with Scotland and the other regions.
And I think the last person I see intimating the wish to speak, Professor Mayer.
Just a plea, if we're coming back in a year's time and we're looking at the National Delivery Plan for Telehealth and Telecare and how you've met your targets, to make sure that you look at the socio-economic profile of those you've targeted to see what the mix is of those who you've actually managed to achieve, because that would be interesting to see if you've managed to reach the hard to reach as well as those less so.
Okay, thank you. Are there any... Mr Templeman, do you want to come in?
I think it's to reiterate, there's great strength, there's great focus, there's great direction of travel. We've got a real opportunity to capitalise on it. And I know that George and Justine and Mark and Stuart and Francis are all involved in that. It's quite important that we take advantage of that now, and that we take that initiative in Europe, and we drive that for our own benefit for our health service, individuals, but also for our businesses.
Thank you very much. And I think the last word, Ms Giannini.
Yes, just very briefly on following up on what Stuart was saying about innovation, which is very, very true even at European level. It's exactly the concept of innovation that we see at European level. It was mentioned Horizon 2020, which is the main funding framework for research and innovation, as opposed to research and development, which was the name of the predecessor program. And innovation in that context means not just technological innovation, but social innovation as well, economic innovation. So really Europe, and the main policy and funding in Europe are really looking at innovation from different angles, and really integration in this, because integration came up quite a lot, is a way of looking at innovations, an integration of technology, policy, managing, so the public sector, the private sector, and the end users, so the patients as well. And we see a lot of, if we go down very briefly into the actual calls that are out at the moment for bids, there are a number of calls for proposal looking at patient self-management, how to empower patient in the context of the e-health. So certainly everything that has been said here is very much in line with the European priorities for the next 7 years.
Okay, I thank you very much for that. In fact, I thank all of the witnesses for coming along here this morning. Now this afternoon, I see looking at the time. I'm sure this is something the committee will wish to return to. But before we close, can I say I'm sure on behalf of all the committee members that we very much hope the Life Kick application will indeed be successful. And thank you once again for your time. And we now close this afternoon's meeting. Thank you.